mentioned a couple times that we were going to be in this room. But what I was saying before you guys walked in is that each pair is only going to have a half hour's time worth of help. So we do want to try to keep this discussion on topic. If it starts to go off topic, then, you know, feel free to say like, hey, Sarah, let's bring it back in. If I start to talk about music or anything like that, that doesn't have anything to do with your guys' assignments, then just let me know. I won't get mad. But we do have to keep it kind of on topic. So, who feels like going first? Okay. So she just volunteered for you. Who's your Theo? Okay, so they're gonna go first, and what they're gonna do is they're going to discuss their patient. They're gonna discuss their diagnosis. They're gonna discuss what assessment findings they see that relates to the diagnosis, and they'll
Remember on this one, these two had a lot of problems because it showed so many, and I couldn't find it on the book. So if I don't look back.
Okay, that's fine.
I'm just gonna skip the help. So I get all that.
Yeah.
So this one's just
So we'll let them have the floor. Now, one thing I did want to do, let me turn this on real quick. I'm going to project up on this board a list of nursing diagnoses. So as you guys are listening to the presentation, I do not want to see people on their phones. I do not want to see people reading. I do not want to see people not taking this serious. I want you guys, because this is a group effort on trying to find each other's nursing diagnoses. So when it's your turn, your classmates are going to be doing the same thing, listening to what you have to say, and critically thinking what nursing diagnosis fits this patient. And I'm going to put up the list on the board.
Sarah, real quick, I brought an extra jacket.
It's not mine.
No, it's mine.
Oh.
So I brought an extra one.
Oh, I'm okay.
Okay.
Yeah. I gotta get ready for ski season. I have to freeze myself out a little bit, but thank you.
No problem.
Let me see the keyboard real quick. So in order to find the nursing diagnoses, you can just simply go to Google and you want to look up NANDA, NANDA, nursing diagnosis. There's the list. Let's go back. Just hold on the page. Let's see. There. Can you guys see that? Okay?
Yeah, kind of.
Maybe one word.
Yeah.
No, but look at how long the list is.
We just want to know the big, depending on what it is, like.
No, because it depends on what the patient is.
Yeah. Once we find out what the issue is, you could go to that section in Zoom.
So we just want to know like the class part, like to see. Is that what you're saying?
I know I found lists that were just like a one-page deal.
young.
What the images?
Of
course you will.
For real.
What happened?
They show like half of what you need and then make you pay for the rest.
Is that what that is?
There's a way to bypass it, but I'm not sure how to do it yet.
My girl had that one. When I was in microbiome.
Oh, my God. So much.
Yeah, it's really hard. Lucky I got like a 98, bro. It was all online.
I do.
We had to do like the iPads and like the simulation. That show was hard. Yeah. It was hard. It was harder online. Yeah, but it's still way easier.
Try, when you search it up, try using open source.
I don't know what that is.
It's usually like public.
All my Zoom
Like you put that in the search bar.
Same. I was trying
Okay,
presentation again.
this one looks better.
Yeah, pretty much.
Can you guys see? Yeah, you guys can see that.
Is
You
that all
guys
of them?
can see that, right?
I can see that. Is that all of them?
Hold on. Whoa, whoa, whoa. I think this is a decent list of them. Yeah, okay.
That's the one we're using. So you're just gonna.
Pretty soon I'm gonna be 60.
Yeah. So you guys go through it and they brainstorm and they look it up.
So what I have to do that was
Not for you, for them.
Okay.
But I want it up on the board so they can be thinking while listening. Saying, okay, well that one. So go ahead and pull out like a notepad so you guys can make notes on which one you think is best, which one you think applies to the patient.
Do I have to read all this out or what do you want me to
Well, if there's a normal stuff, you're gonna let your class know
Yeah.
so that way they can make a diagnosis on it.
Okay.
So you do want to kind of go through the whole thing.
Pulse.
Yeah. And blood pressure.
That's respiration.
But you don't want us to talk about anything like mental.
Nobody had a mental diagnosis.
Yeah.
You could say, oh, this mental health condition may apply,
Radio pulse.
but as far as studying, you're going to have a whole semester that's dedicated only to mental health.
Okay, what's this one? Oh, it's right here. Okay. There?
Yeah,
So
the floor is yours.
Okay, so I cannot say the patient's name, no, but just
No name.
okay. So we assessed one of our patients, male. He was admitted at Canyon at 218 pounds when he really came in. So he's now at 480 pounds. And his vital signs were temperature was 96.6. His radial pulse was 70, respiration 16, blood pressure 144/86. So levels of unconsciousness, mental status, he was fully conscious. So patient is fully alert and oriented, knows his name and place and his situation and what's going on. His emotional status is he was really cooperative, really talkative, and really cheerful. He didn't hesitate in anything. He let us do an assessment on him, so he was really good with that. Speech, perfectly. He was clear and everything, so patient was fully clear when speaking. Eye pupils. My comments were patient has good eyesight and does not use any eyeglasses. Theo went ahead and made the eye exam with the light, so he didn't have no issue. He followed the light, so
His eyes was parallel.
good.
It was per limit.
Pupil
Pupils equal,
equal
round,
round.
and reactive to light.
So, ear, nose, and mouth. Comments me and Theo put together was patient nasal mucosa is pink and moist. Eyes are clear and no abnormalities. Ear canal on both ears are clear. Skin, he had, warm skin, and it looked good. Just patient skin is hydrated from the upper part of the body compared to the lower part of the body. It was more dry due to he has lymphedema and obesity. Am I doing right?
Yeah, no, that's fine. I'm just gonna come over here and make some notes.
Okay, so lungs were clear, and abdomen, patient's abdomen has distension larger than normal due to excessive weight. Extremities, none. If he's on any type of equipment, none. Summary of our findings where a patient has morbid severe obesity due to excess calories, lymphedema, localized and swelling in large lymph nodes on both right and left legs. So both of his legs had, they're really swollen. He had open wounds due to H2O. He holds water, and that caused him to have two large open wounds on both sides, left and right leg. Medication, he's taking how do you say it?
Acetaminophen, which is the
Yeah.
same thing as Tylenol.
Okay,
Tylenol.
I can pronounce these medications.
You gotta practice.
Okay, Docusate sodium, 100 milligrams. That's for loose stool. Acetaminophen, that's for temperature. Ducalox, for constipation. Fleet enema, constipation, and then he's just basically which one? This one? Okay, he's taking Ducalox suppository for constipation. So he's basically on a lot of medication just due to constipation, and the only medication he's taking is the multivitamin minerals. That's the only thing he takes. He's on Tramadol and Voltaren, but he is not. He's actually rejecting that medication. He doesn't want it. So he's just on an everyday basis. He's just taking the vitamins. This one, do you want me to read or?
Okay, so, with lymphedema, one of the things she had a hard time accessing and finding was medical treatment for lymphedema. So here, Mayo Clinic is a very good website for you guys to get resources on. So when we come here, we have here treatment, and right here with the treatment, it says there is no cure for lymphedema. Treatment focuses on the swelling and preventing complications. So reducing swelling. How do we reduce swelling? So a couple medications to reduce swelling. How do we reduce swelling? I heard one which was a medication. which is a diuretic medication. What do diuretic medications do?
Sodium.
Makes the patient's pee excess fluid. That reduces swelling, right? Less fluid in the body, less fluid that can sit under the skin and cause swelling. What else can we do? Which one? Aspirin, not really, because that does nothing to get rid of fluid. Go ahead.
By
Now, how can you drain it? It's not an abscess. There's nothing we could poke a needle to and let the fluid leak out, because the fluid is in our third space. So you guys have heard of third spacing? So third spacing is, it's not inside an abscess, it's not inside a vein, it's in our, they call it interstitial tissue, but it would like be swelling of the fatty tissue or that subcutaneous layer, or layers that are in between our muscles and veins and stuff like that. So, or sometimes you'll even see it like kind of at the surface of the skin, and what you'll do is, to assess it, you push in and you're looking for edema, which that should be on one of the assessments. So you're assessing for edema. You're going to look for pitting edema. It should be somewhere on here. Right here, pitting edema. So +1, +2, +3, +4.
so all of them.
So no, it'd be whatever you see on the patient.
So it was
So with
really
pitting
good.
edema, you put your finger and you kind of squish the skin. Completely honest,
Oh yeah, I remember doing
I
that.
actually have pitting edema myself. So let's see what I got going on. it's
So right
it's
there-
bad. Yesterday it was pretty bad.
So Sarah,
So-
1, 2, and 3, and 4, those are different stages.
So come closer. So when I push down and I let go,
1.
see how I have a divot in there? Yeah. I have pitting edema, y'all. You want to come see?
So when you count 4,
That's a mosquito bite. But when I push down right here, and usually it happens like after I work, so you guys are lucky I worked at the hospital yesterday. So I push down right here, and when I let go, you see my pit.
yeah,
That's because I'm
you can
swelling.
feel it.
You can also see like pregnant people get it too.
So that Sarah, that's when it says
That would be pitting edema. So like this is probably like a +2.
okay. So
When
no,
it,
yeah, we did
when
ours.
it
So that was
stays
like a
real
1.
deep, that's when it gets longer.
That's a +4, right?
Now, pitting edema is excess fluid. So what should I do? Probably exercise will increase circulation. Yes, so if I were to go for a walk and I exercise, now what do pregnant people do when their feet swell?
They put it on the pillow.
Elevate them.
They elevate them.
Yeah.
So that's another thing we can do.
So Sarah, when we did that to our patient, which I remember, since he's so heavy, I mean the skin would just kind of just bounce back. So it's not like your side.
Well, I also held mine down for a long time just to make it dramatic. So you would have to see how deep it makes. If it's a real deep one,
Yeah.
then it's +4. If that one was probably like +2.
Mhm.
Sometimes if you only see a faint outline of your finger, that would be +1.
Yeah, that's what we were
So to treat it, we want to elevate. So after about like a week of not working at the hospital, I can check for my pitting and I won't have any. Why? Because I've been laying in bed, lounging with my feet up. Usually I'll put my feet up on like 2 pillows. Now, they always say people who work on their feet a lot, what are you supposed to wear? Compression socks. So don't you think compression and wraps can help?
seeing. Yes.
Compression or wraps can be a treatment. what else can we do to help swelling? So we want to increase circulation. So we can increase circulation by
What
doing a
about-
massage.
He's eating like salt and stuff like that. Putting that.
So I hear eating salt. So what happens with the relationship between salt and water?
Wherever salt goes, water follows.
Wherever salt goes, water follows. So the theory is if we take less salt in our diet, we keep less salt water in our body. So what would they call that?
No sodium.
Sodium restricted or low sodium, same thing.
And then it would be like a 1 like that, 6 to 18.
Now that's more for like weight gain. So let's consider when he first started attending that facility. What was his weight?
218, right?
Yes.
200. And now what is he at? 400.
80.
So when patients dramatically increase their weight, very, very rarely is it fat gain. What weighs heavier than fat? Fluid and water. So if he dramatically gained weight, like 200 pounds within the past month, is it physically possible for someone to gain 200 pounds
No.
in that short period of time? No, physically impossible. So what is the cause more likely to be?
Water retention.
Fluid and water retention. So we need to focus on reducing the swelling. So is it really a weight problem or is it a fluid problem? Now for him it may be a combination of both. But our focus today, right now, is the fluid because that's related to lymphedema. Fat is not related to lymphedema. Fluid is. So what lymphedema is means our lymph nodes. Lymph nodes are responsible for carrying excess fluid and carrying some of our immune items like cytokines and white blood cells. White blood cells, yes, they are in the veins, but what happens when they migrate out of the veins into an infection area? They do move outside the veins. That's when they would move by lymph. So what happens is the lymph is able to move, but it's not getting absorbed back into the lymph system easily. So that causes that swelling. So our focus is reducing the swelling. What are some other things we can do to increase circulation?
Walks. No.
Walk and exercise, right? Now when we read here further, we have a list of therapies. So there's medications. So lymphedema increases the risk of skin infections, also known as cellulitis. Your doctor may prescribe antibiotics to keep on hand so you can start taking them immediately once symptoms appear. So that means once the patient sees that wound in that leg, they start taking antibiotics. What was one thing we saw on her patient? What about the legs? She said the skin was flaky, but there was also wounds on the legs. So he should have been taking antibiotic. Then we come here and we look for exercise. We got that on there. Walk and exercise. Manual lymph drainage. So therapists trained in massage-like techniques use light pressure to move the trapped and trap fluid in the swollen limb towards the area of the working vessel. People should avoid manual lymph drainage if they have an infection, blood clots, cancer in the affected limb. Then we have compression bandages and compression garments, or sequential pneumatic compressions, which they sit on the lower leg and they squeeze.
Can they use this when they have to open wounds?
Yes, they can.
They could?
Yes, they can. So they can still use compression bandages and garments if they have open wounds. Yes. Then they have other things, which is a lymph node transplant. They can have new drainage paths, which is only used for early stage lymphedema. So if this guy has gained 200 pounds of fluid, is that early stage?
No.
No. Removal of fibrous tissue. So in severe lymphedema, the soft tissues of the limb become hardened. Removing this hardened tissue, often through liposuction, can improve the limb's function. In very severe cases, hardened tissue and skin may be removed with a scalpel. So that's where the doctor would have to debride that. So did this patient have any of those surgical treatments?
No, he's waiting for surgery.
He's waiting for surgery. So when we look at these treatments, do we need a doctor to prescribe diuretics?
Yes. Yes.
Do we need a doctor to tell us to elevate the leg?
No.
No. Do we need the doctor to order compression wraps and garments?
No.
That's wound care, yes.
Oh yes.
Oh, never mind. Oops.
Do we need a doctor to tell us to massage?
No.
No. Do we have a doctor's order on the diet?
Yes.
Yes.
Yes. Do we need a doctor to tell us walking and exercising?
No.
No. Do we need a doctor to prescribe antibiotic to
Yes.
treat the
Yes.
infection? Do we need a doctor to do surgery?
Yes.
Yes. So this tells you the difference between what our nursing care and what our medical care is. So now let's go back to our list of nursing diagnoses. There's one, let's see. So, number 63, what do you guys think of that?
Yeah, I say because he has a wound.
He has the wounds to the leg. Now, what about number 31?
31.
Excess fluid
Excess
volume,
fluid,
yeah.
so he's retreating the fluid.
So, without the fluid, would the wounds be a problem? No. So, what do you think for him our priority nursing diagnosis would be?
The fluid.
And reduce
The
fluid.
fluids. So fluid volume excess. Number 31 would be our top priority for this guy. So we had 8 more minutes till your group is done. See how quickly that half hour
So a
goes?
nursing diagnosis
quick.
will be.
It's very quick.
So nursing diagnosis.
So your priority nursing diagnosis would be excess fluid volume. Number 31. So when we write out a nursing diagnosis, we get our first part NAMDA. So excess fluid volume. Then we go, oh, this one's the bad one. Excess fluid volume related to, now related to is, we need that, in order to get the related to, we need to know our pathophysiology. So our pathophysiology would be what changes happen to the body to make our excessive fluid volume. So excess fluid volume related to now could I say related to lymphedema? No, because we don't use medical diagnoses in our nursing diagnoses.
Be lymphatic.
So it would be related to enlarged lymph node. Related to enlarged lymph nodes as evidenced by. Now, what is our evidence that the patient has excess fluid volume?
The swelling?
So let's think about his assessment only. So I hear weight gain. So plus 200 pounds in, we'll just say 1 month. What else? The edema. So you said his was pretty bad.
Yes.
So we'll just say +4 pitting edema. Can everyone see it? So see how this evidence is proving this. This evidence is not proving this. See how that's written for the nursing diagnoses? So this would be the full nursing diagnosis that is very patient specific. So when we write these nursing diagnoses, we want these to be patient specific. Yes.
Can you repeat what they are, like excessive fluid volume?
So excessive fluid volume, this is the NANDA nursing diagnosis that we pulled from here. Related to, this is the change that caused the excess fluid volume. So related to the enlarged lymph nodes. Because those lymph nodes weren't working, we have excess fluid volume now. See how that kind of works?
So,
Then, as evidenced by, this is our proof showing that the patient has excess fluid volume. Cool? Now we're going to go over this 6 more times. With your each of your classmates is going to get a new working through. So then we're going to take this excess fluid volume and we're going to look into the book. This we can't do right now. So this is the main point of the whole presentation, to get this statement. Then we take this statement, we go into the book. Cool?
that's it?
Mhm.
Oh, what? Okay.
That's the presentation.
So right here, my goal, it would be to just,
So the goal is another thing we would gain from the book. So we gotta finish up here and then we go into the book. So my friend just sent me a picture of the news and it says the most dangerous cities. Number 3, San Bernardino. Number 4, Detroit. How did we get worse than Detroit?
See it?
And then it says safest California cities, Irvine, Chula Vista, and Glendale.
The safest?
Safest. Isn't that crazy? You guys, we gotta do better for our community. We gotta do better for our community. It's wild. Okay. Where did they go? This is not break time. So who wants to go next? We're running out of time. Come on.
Why did you say no?
Huh?
I want to go left.
Sarah, when you talk about the book, it's our nursing handbook.
No, it's a nursing diagnosis book. It's not here. We have to go into the other room to get it.
Oh, okay.
Okay. So go ahead and discuss your patient.
Our patient is a 73-year-old female. We'll also read the diagnosis.
Let me take a peek at what it is. Diabetes? Oh no, you did gastric ulcer. Okay.
Should I just read this?
No. You can just say, oh, they have a history, but our diagnosis is gastric ulcer.
Our patient has a history of type 2 diabetes, depression, malnutrition, obesity, substance and alcohol abuse, and gastric ulcer. But we are doing the diagnosis on the gastric ulcer. She has no known allergies, and her physical description is that she has signs of dehydration, poor skin turgor, dryness in her mouth, skin, fatigue. Psychologically, the patient is happy, enjoys the company, participates very well in the assessment. Her past medical procedure is breast cancer, hyperlipidemia, hypertension, history of type 2 diabetes, and substance and alcohol abuse.
Okay. With the vital signs, the temperature is 96.2, pulse is 89, respiratory is 12, BP is 120/55, and the pulse oximeter is 84. The level of consciousness is full conscious. The comment we have over there is full consciousness, aware of surroundings and questions being asked. Orientation, person, time, place, and then situation. Patients knows who she is, what time it is, where she is, and why she's in acute care. Emotional status, she's cooperative, cheerful, and happy. Comment, cooperative and very descriptive with assessments, but gets emotional when talking about family, past loved ones, two possible cause for her depression. Speech, she is clear and cohesive. Comment, clear and cohesive speech, fluent with her answer. I, we have reactive. Okay, we have reactive and then white, and then we have parallel. Comment, reactive to light, constraints to two on scale,
And dilates to 7 when not reacting to light.
Ear, we have so what? W and L, and then the nose we have W.
That's good.
WNL means within normal limits.
Okay. Then the mouth we have pink and then moist.
Oh, dry.
Oh, dry, sorry. The comment is mouth color is normal, healthy, but slight cracking in lips and tongue due to dryness. The skin, we have WNL. No, we have pale. Yeah, we have the pale. And then the comment is pale and scaly skin with noticeable skin tangle. Cold and dry to the touch, signs of dehydration. The apical pulse is 89 and regular. The rhythm is regular.
Her lung sounds are normal. Rates are regular. Lung sounds are good. Slightly shallow. Her abdomen has no distension. Her bowel sounds are hypoactive. She has noticeable scarring on her abdomen due from daily insulin administration. Her extremities, radial, are palpable. She has good full range of motion in her arms and shoulder, though poor, with less movement from being in bed and from her overweight. Her nail beds are pink. Capillary filling time is less than 5 seconds. She's not using any equipment. And
So one question I do have is when you guys assessed her, and you guys palpated the stomach, was there any tenderness?
I just feel maybe.
She didn't say, oh, there's a little pain
No.
here?
No,
No,
She reported no pain?
She said pain only when she's eating spicy.
So she says pain when she eats spicy food. Did she mention anything about having a heartburn feeling or a lump in her throat?
Heartburn feeling.
Okay. Now, what was your pathophysiology?
I don't know if I did this right.
It's okay.
Like, describe the client's diagnosis through the textbook. Gastric ulcer is either from a bacteria that colonizes the stomach or the use of non-steroidal anti-inflammatory drug. And regarding the bacteria induces an inflammatory response in the host that leads to an epithelial response, degeneration, and injury known as gastritis. The use of non-steroidal anti-inflammatory drugs is also known to cause gastric ulcer. The drugs themselves are weak acid. When they're exposed to gastric acid, they remain in the epithelial cell and lead to cellular permeability, which leads to physical cellular injury.
Okay. Very good. That was good. So his pathophysiology was very detailed. Now, as a very quick statement for gastric ulcer would be it's a degeneration of the epithelial tissue. So we have our stomach. Here's our stomach. And in our stomach, to prevent our stomach from burning with this stomach acid. Ooh, look at that nasty stomach acid. To prevent our stomach from burning up inside, what we have is our epithelial tissue, and it's a lining. And it's almost like a skin for the inside of the stomach. So our skin is our first line of defense. So if that first line of defense degrades, then what happens? What happens with that stomach acid? It burns. Oh, it burns. That's why people will have pain after eating. Because they eat, stomach acid increases, then the stomach acid gets to that degraded tissue. It burns. So they'll feel burning if it's a gastric ulcer right after they eat. So they eat and it burns as it goes in. Burns. Like, burns. If it's a duodenal ulcer, you'll eat and then 30 minutes later, oh, it burns. So this patient reports eating pain with eating after eating spicy foods. That's that lining of the stomach getting degraded and it burning through. Now here's one of like those crazy stories. So we had a patient with stomach ulcer, and that particular area where the ulcer formed and was burning through that epithelial tissue, right underneath was an artery. So it had finally made its way through, and the patient chill all day. Probably around like 6 to 7 p.m. like exorcist throwing up just straight blood. So we call up the GI doctor. Hey, GI doctor, emergent. They come in and they go down with the scope and they have to do that cauterizing. So they go over this area and it's, in order to stop the bleeding, they have to burn that blood vessel closed. Cautery. So thankfully the patient got that and he was okay. Yes, we did have to transfuse a lot of blood products, but he ended up okay and he survived the night.
Does that later come back and heal?
So that layer can come back and heal, but we have to use medications. We have to use medications. So let's let them continue and we'll talk about the treatment for gastric ulcer. Now this is a very common problem and some of you may have this issue and not even know it.
You do have it.
You may oh, I do. It hurts too. Sometimes you'll get a stomach ulcer when you know how like blood has that metallic kind of smell or taste. You'll taste like metal in the mouth, almost like you've been like sucking on a spoon.
Wow.
Oh yeah.
Interesting.
If any of you guys have had like a metallic taste in the mouth, maybe you guys have had a stomach ulcer.
Is that when you have your, like when you're pregnant and you have that acid coming out?
Yeah, that could be the same thing. Now, acid coming up is called acid reflux,
Yes.
which is different than an ulcer. An ulcer is when that acid gets bad enough that it starts eating the lining of the stomach. So for treatment, how do we want to treat this?
Medicine.
But what do we want to reduce?
Increase the pH level.
So we want to reduce the pH of stomach acid or reduce the secretion of the stomach acid. So what are some treatments that we're going to do to help reduce the acid of the stomach?
Diet.
Diet.
Did you guys look up the medical treatment? Okay. What are some things we're going to do?
The first is to increase the pH of the stomach, which you already wrote,
Okay,
to
so
allow the stomach to heal.
decrease pH of stomach. We're going to use what we call antacids. Antacids are the same thing as Tums. So what that does are they're electrolytes that work to neutralize that acid. So to decrease the pH, we're going to give acids.
Isn't that increased because
So, sometimes with antacids, we do have to be careful. Because if you take the antacid and it reduces the level, the pH of the stomach the stomach is going to say, hey, I'm supposed to be at a pH of 3 and we're at a pH of 5. Guess what? My stomach's not working right. I'm going to produce more acid. So one thing we do have to be careful with giving antacids is rebound acid production. That means the stomach starts producing more. So when we do antacids, typically we'll want to do other medications with it, not just the antacids by themselves. Go ahead.
the doctor, depending on the severity of the examination, will recommend a PPI, which are medicines that reduces the amount of stomach acid made by the glands in the lining of your stomach.
So a PPI is called a proton pump inhibitor. That's a certain type of classification. So PPIs could be medications like Protonix, Pepsid, Omeprazole, and how do I spell it? ESONPR. Also known as Nexium. ESO. ESOMEPRAZOLE.
Can you repeat what PPI stands for?
Proton pump inhibitor. So what those do is it actually tells the stomach, don't make any more. So that blocks that rebound from happening with the neutralizing the acid. Okay, what else do we have?
We have the nursing care management.
Well, there is one more medication that we do give, depending on the type. So this reduces the acid. This one stops the acid from being made. Now, what can we do to stop the acid from going to that ulcer?
Is it
When we talk about wounds, we put on a barrier, right? Can't we put a barrier inside the stomach?
Yeah? Maybe?
That's where we would think of the liquid. So things like Maalox, things like Carafate, things like Pepto-Bismol. What those do is when we take the liquid in, it coats the lining of the stomach and creates a barrier from the stomach acid to that epithelial tissue. So when we do that barrier, those three are gold standard for gastric ulcer treatment. Okay, so now we're going to talk about nursing care.
For nursing care management, provide the patient by educating about gastric level and stomach pH balance. And once the gastric ulcer is healed, the patient needs to avoid foods that lowers the pH, like spicy foods and alcohol, and consult primary care regarding drug also that causes the gastric ulcer.
So teaching about drugs that cause gastric ulcer. So one thing he said in the beginning were non-steroidal anti-inflammatories, also known as NSAIDs. Has anyone have seen the word NSAIDs written on the bottles at home? You should have.
Yeah.
If you read your bottles appropriately, you should have. What medication is in the classification of NSAIDs?
Aspirin.
Aleve, yes. Motrin,
Yeah.
also known as ibuprofen.
Yeah.
Oh.
Aleve is also known as naproxen. Those are under the classification of non-steroidal anti-inflammatories. Those medications are notorious for increasing stomach acid. So diet restriction. We have that under nursing care, but what would the doctor order as far as a medicated diet?
Well, spicy.
Low spicy. What is a type of diet that we hear of that has low spice? Bland diet.
Yeah.
Ew. Bland diet. Now there was a surgical or procedure that I saw on your paper real quick. Under the medical care, it was right here.
Oh God.
I know.
Esophagogastroduodenoscopy.
OGO. Esophago, gastro, D-E-N-O. Did I spell it right? Did I spell it right?
That doesn't seem right, but
Who can say it? Esophago, gastro, duodenoscopy. Also known as, are you guys ready for it?
Yeah.
An EGD. And you will find it referred to EGD all the time.
So no one's gonna ever, well,
Oh no, so when you write out a consent form, am I able to write out EGD?
no.
You have to write out the full legal term.
Dang, that's
But not only does it, not only do I have to write out that, I have to write out with cautery, with possible biopsy, with possible sclerotherapy. So it's going to be the entire course of treatment that the doctor may use. So what happens if I don't put in cautery and the patient needs cautery?
How would they know?
Wouldn't that get you in trouble?
You don't know, so you put in all possibles. But if the possible isn't listed on there, can we legally do it?
No.
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 You gotta
So
get
that means if I needed cautery, I would either have to call up a family member and say, hey, we didn't consent for cautery, but the patient really needs it. Or we stop the procedure, reschedule a patient for another day. That means a whole nother day of prepping, a whole nother day of getting time off work, a whole nother day doing it all over again. So it's best just to consent them for all possibilities if needed. So perform an EGD. Now when I talked about that patient with the bleeding ulcer on the inside, we had to go in and do an EGD and cauterize that area that was bleeding. Because it was like blood everywhere. It was a mess. Okay. So we got some treatments up here. What are some things that doctors need to do?
Yeah, okay, that one,
Prescribe,
yes.
prescribe, prescribe.
I don't think we need anything to educate.
Now one thing also when we talk about these meds and prescribing, a nursing intervention would be to
Administer the drugs.
administer nursing, educate nursing, educate on diet restriction nursing. What about bland diet? Prescribe. What about perform an EGD?
That's definitely a doctor.
Prescribe. Doctors do that. Order, prescribe, same deal. Okay. So when we look at our list of nursing diagnoses, which ones do you think would be good ones for the patient?
Let's see.
Educate.
Is it acute pain? Is that one?
You can use this.
So when they eat, we can have acute
Acute
pain.
Who's that one? Oh, 52, yeah.
Has any of you guys had heartburn before? Did you feel nauseous?
Yeah.
I think so, yeah.
Number 48. Now, one thing I also heard a lot from the physical assessment was impaired oral mucous membrane because the mouth was dry. What is a big side effect of medications?
Oh,
Dry mouth. And the patient displayed dry mouth in their assessment.
What is dry mouth?
Which one?
What would I put for the dry mouth? Is it just dryness?
Or dehydration.
Well, you would see impaired oral mucous membrane, but we're not going to use that word. Okay, so when we write out the nursing diagnosis, when we think of nausea or acute pain, did the patient report nausea?
no.
Even though that's something we may experience when we have heartburn, doesn't mean that the patient was experiencing that. So we're not making nursing diagnoses on ourselves, we're making them on the patient. The one thing that the patient did report was acute pain after eating spicy food. So acute pain related to what was causing the acute pain?
Bacteria or enzymes.
Degeneration of epithelial tissue.
Degeneration of epithelial tissue. As evidenced by
So is that the diagnosis of that?
as evidenced by what did we see with the patient?
Pain and heartburn.
Pain and heartburn feeling when eating spicy foods. Now, how come I can write heartburn?
Is that a diagnosis?
No, it's not a diagnosis.
Subjective.
She didn't report pain in her chest. Which is
So,
usually the same.
heartburn is a street term. What is the medical diagnosis for actual heartburn?
Guess it-
Acid reflux, but it's more specific than acid reflux.
Isn't it a GERD?
GERD. What does GERD mean?
Gastroesophageal.
So gastroesophageal reflux disease. So what's happening is you have your stomach down here, and we have our esophagus that goes into the stomach. What happens is sometimes this valve we have, which is called the cardiac valve because it's close to the heart, that cardiac valve will become weak and relax, and that always stays open. Then acid from the stomach can travel its way up into the esophagus. Does our esophagus have an epithelial lining? It technically does, but it's not made like the stomach's where it acts as a barrier to protect. So the esophagus can get degraded much, much faster than the stomach lining if they have GERD. If that valve is intact, they don't have the stomach acid coming through. So yes, can the esophagus get ulcers
Yes.
if they have GERD bad enough? What typically ends up happening is if a patient has uncontrolled GERD for a long period of time, is that lining inside the esophagus gets slowly but surely touched by acid, and it's only a little bit. It's not as much as like the stomach storing it, but it gets those little touches. Then what happens to the cells is from being exposed to that acid, the cells start to mutate and change. When the cells mutate and change, what does that cause? Cancer. So a lot of people who have uncontrolled gastric reflux later on in life can end up with esophageal cancer. Bad news bears. So it's funny because I personally know two people, one person we talked about the last thing, now another person with this one. So the last one we did lymphedema, which is my brother-in-law. So he was in Iraq like 10 years ago, and from putting on those boots he got an infection. That's what started it, but with infection comes swelling in the red blood cells. So that went on, infection on and off for about 10 years. So now he has lymphedema. So one leg is normal size, one leg is like double the size. So he has now gotten so many infections that on November 9th, he's getting his leg amputated. the boots. Well, because in Iraq they don't quite have good shower facilities. So,
They wear the boots in the shower.
and when you wear the boots, day in, day out, day in, day out. When you go skiing and you have boots, at the end of the day, especially if you get rental boots, what do they do with those boots?
Spray.
They put spray, but they also put them on boot dryers. Because you need to dry out those boots. In Iraq, do they have luxuries like that?
No.
No, so the boots get very moist. This was another big thing with people in the Vietnam War, is because it was so moist. Have you guys heard of, I think they called it like jungle foot. So basically they would take their boot off and their whole foot would be a giant fungal infection. Same thing with athlete's foot. Athlete's foot is a fungal infection because the feet aren't getting dry enough. So by not letting them dry. Now thankfully for him it was only 1 foot. But it went untreated, untreated, untreated. Then he went to the VA, they didn't want to do it, and it was back and forth, back and forth. Then now it's bad enough. He has the thickening of the skin, he has all that stuff. Oh, that's the 30 minutes. He had all that thickening of the skin. Now, same thing with my uncle. He has really bad heartburn, and, you know, he's had it since a kid. Over and over and over and over, and now he has esophageal cancer. So, it's crazy. You just gotta treat your body nice now.
Yeah.
I mean,
Is that like, I say it's like kind of like you develop as a kid?
you can have heartburn as a kid. Now, if you are a kid and you eat lots of Takis, is your risk of heartburn a lot higher than someone who didn't? Oh, yeah. Now, what about a kid who's anxious and is stressed about a whole bunch of stuff? Stress causes increased stomach acid too. Stress. So if you guys notice throughout this program, you may be a little more stressed. Now, what about coffee? Wild heartburn. What about spicy foods? Yes. Greasy foods. I had Popeye's chicken sandwich last night, and at 11 p.m., I woke up with wild heartburn.
So this one's right too?
Was it the spice?
No, not even the spicy one, just the grease. Now, another thing you can do to help treat stomach acid is going for a walk at night before going to bed, because that increases that GI motility. Another thing you can do is stop eating at maybe 3 or 4 hours before you go to sleep.
Sometimes when I just got out of the bar and I'm like super fucked up, I go to Cane's and it's just so much bread and I passed out, like, and I feel the next morning like,
Stomach hurts.
reflex.
Yeah, it hurts.
Hey sir, I was just wondering, in terms of like people like say they go out drinking, right? And like
Did you guys write this down?
Yes.
Okay,
I got you.
go ahead.
oh yeah, people like drink, right? And say if like they get like wasted like over and over and over and like they vomit a lot, like will they eventually get like ulcers from like all that like you know?
So another thing that increases stomach acid like wild is alcohol. Now, a majority of the time, patients that I see have bleeding ulcers are alcoholics.
Blame it on the
9 times out of 10, it's an alcoholic that has bleeding ulcers, not people who take NSAIDs, not people who have H. pylori, which is the bacteria that causes stomach ulcers. 9 times out of 10, from what I see, is people with bleeding ulcers are alcoholics. That's beginning stages of alcoholism. Wait till later on where the skin turns yellow. Then they start bleeding out of everything. I have seen patients bleeding out of their mouth, bleeding out of their nose, bleeding out of their eyes, peeing blood and shitting blood.
That's so
I have
terrifying.
seen it. That is end-stage liver failure. The ugliest death. They're yellow and they look like a highlighter colored them. their eyes, then they start getting puffy and swollen.
Oh,
And their
my.
stomach, that's where that beer belly comes from. Because their stomach fills with fluid called ascites fluid. And it's like they're 9 months pregnant. And the rest of them are like skin and bones. Because a big thing with alcoholism is they have protein deficient malnutrition. And yeah, it's
So a beer belly is like their stomach.
ascites.
It's their stomach.
So it's not their stomach, it's fluid collecting in their stomach. Not in the stomach
the
organ, but in their peritoneal space.
okay.
Yeah. Alright, ready? Here we go.
Okay, so our patient is 33 years old, male, who's white and Hispanic, and he's been diagnosed with hypertension and hypothyroidism. And he had a fall which he has a displaced fracture of posterior process of right tibia, closed fracture there, displaced fracture of posterior or process left talus, displaced fracture of body of left calcaneus, and unspecified muscle wasting and atrophy with abnormal posture.
I'll do this one or that?
Yeah, you got it.
Okay, for vital signs, we have the temperature of 98 degrees Fahrenheit. The pulse rate was 82. Respiratory was 22. For blood pressure, it was 136/96, and the pulse oximeter was 99. The level of consciousness was that our patient was fully conscious, and he was orientated. He knew who he was, the time, the place, and the situation. Also, the emotional status, he seemed to be relatively happy, cooperative. The speech was very clear, very coherent. As for the eyes and pupils, the eyes were normal, nothing out of the ordinary. When it came to the ears, nose, and mouth, again, everything was normal. Skin, very normal as well. In terms of heart rate, the apical pulse was 88 with a regular rhythm.
Okay, so for the lungs, the breathing sounds were clear, and the rate was regular. For the abdomen, it was symmetrical with no distension, and the extremities had good movement, except for his legs because they were in a cast and he was in a wheelchair, and he didn't have any equipment on besides the wheelchair with walking boots. And the medication he was on was. Alright, do you want to do. Like, I'll do half and then you do the rest?
Yeah.
Okay. So he had acetaminophen every 4 hours for mild pain, aspirin once per day for DVT prophylaxis, Wellbutrin and bupropion for smoking cessation, cholecalciferol once a day for vitamin D deficiency, decusate sodium for stool softener, biscodol for constipation, fleet enema for constipation, gabapentin for neuritis, heparin sodium for DVT prevention.
The line?
Yeah.
And then there's heard of penium sodium.
Let me see.
So there's the top one.
And then
In-brain solution.
solution.
In
Right there.
vans.
In-brain solution.
Invent solution, 1 gram IV.
For
Level-
for infection.
For infection. Then there was levothyroxine sodium, 75 micrograms by mouth for hypothyroidism once a day in the morning. Metoprolol tartrate.
Tropolol.
Tropolol. 50 milligram once a day for hypertension. Magnesium hydroxide. Milk of magnesium, 30 milliliters by mouth as needed. if there was no
Bowel movements for 3 days.
for 3 days. Then there's W.
Naloxone for opioid
Oh, okay.
OD.
Oh,
Yeah.
Narcan,
Narcan.
Narcan.
AKA
Narcan.
Narcan.
Then there's also olanzapine, 5 milligrams by mouth, twice a day for schizophrenia and auditory hallucinations.
Olanzapine.
Olanzapine? Olanzapine. Okay. Then there,
Pronunciation a little bit.
I don't
It's
know.
okay.
Yeah. Also, there's oxycodone. I know that one.
Norco.
10 milligrams by mouth, every
4 hours.
every 4 hours. Moderate to severe pain. Then there's trazodone, 50 milligrams by mouth at bedtime, primarily for insomnia. Alprazolam, Xanax, half a milligram by mouth every 2 hours, 12 hours. For anxiety, then there's Zofran, 4 milligrams by mouth every 12 hours for nausea and vomiting. Okay.
And then we go over our meds. So for Invan solution, it's to treat infection. Some adverse effects are nausea, vomiting, and upset stomach. The nursing responsibilities are you have to be cautious of renal impairments, and you have to look at the history of CNS and seizures. You want to teach the patient about hypersensitivity, superinfection, and pseudomembranes. The brand is Intrapenum Sodium. Well, that's an IV. And you can do yours. Yeah. Levothyroxine sodium for hypothyroidism. Some adverse effects are chest pain, decreased urine output, and difficulty breathing. Some nursing responsibilities are to assess the heart rate, the ECG, heart sounds, and to teach them, you want them to take it as directed and swallow it whole. Synthroid is the brand name, and don't exceed 300 micrograms of that a day.
What was the patient's heart rate on the vitals?
And the vitals, let's see, heart rate. The heart rate was, let's see, 86. Okay, and then also he was taking
Metropolol.
metoprolol. The purpose for that was for hypertension. The therapeutic range of dosage for this patient, he was given 50 milligrams, 1 tablet. The adverse effects you may need to reduce before you stop. Also, watch out for depression, drowsiness, and bradycardia. Nursing responsibilities for that particular drug, you check for allergies, assess if the patient has COPD, and also look out for any other signs or symptoms. And for the patient teaching, we would give them 1 a day. We would hold if the systolic blood pressure was less than 110 and the pulse rate was less than 60. And then also another drug that was given to the patient was Zofran, and the purpose for this medication was for his nausea and or vomiting, and he was given 1 tablet. The adverse effects would be for constipation, drowsiness, fever, headache disorder, or diarrhea. Nursing responsibilities for this drug is to tell the doctor if the patient is fainting. Also, make sure that when this drug is taken to not drive or do anything that requires extreme focus, and to slowly get up. The patient teaching is for him to take it every 12 hours as needed for nausea and or vomiting.
Alright, let's go on to the pathophysiology.
Like about hypothyroidism?
Yeah, hypothyroidism.
So for hypothyroidism, it's basically when your thyroid produces too much of the hormone, and that could happen if you have too much. If you have too little, and that would happen if you don't have any iodine in your diet, and if what is it? It's not Graves' disease because that's for hyper.
We call it hypothyroidism.
Yeah.
Yeah.
Now, if your patient gets into severe hypothyroidism, they go into a condition you guys will see in the summer called myxedema coma. Now, myxedema coma. So, what is the purpose of our thyroid hormone? To maintain what? The metabolism. Metabolism, aka our energy source. So our energy source, when it's decreased, what should we expect to see the heart rate do?
Lower.
For hypothyroidism, what should we see the patient's weight?
For hypo, right? Is what
If they have hypothyroidism, they're going to gain weight. What is their hair going to look like? Are they going to be able to grow hair real well?
No.
Because their body isn't functioning properly. So they're going to have thin, brittle hair. What are their nails going to look like? Brittle. They're going to break real easy. They're not going to be very strong. So did you see kind of anything weird with your patient? Like his nails or his hair? I know he wore that like man bun. You
Yeah.
couldn't really like
I mean-
see it.
Yeah.
I think it was just like, kind of like really, really frizzy. I don't know if that's any.
Real frizzy.
Yeah, like very.
So frizz usually happens because the hair breaks.
Yeah.
Like it's the little pieces of hair that you see growing back that causes that like little frizzies.
Mm.
So it could be that his hair was thin and brittle because it was breaking off and it was frizzy.
Smoking doesn't help, does it?
Smoking doesn't help. Now, one thing I did want to mention is he was taking a medication, Wellbutrin, to stop smoking. Now, Wellbutrin is a psych medication also used to treat depression. But what that Wellbutrin medication does specifically is it increases dopamine in the brain. So when patients are addicted to things, they're addicted because they receive that dopamine rush. So even though the patient may not have reported depression per se, they're using it to increase dopamine in the brain to make him stop smoking. Got that? Cool. But let's go on now to the treatment of hypothyroidism. What is some medical care and nursing care? So our goals for the hypothyroidism is to increase thyroid hormone. What is some medical care that we have for that?
Diet.
What kind of diet?
Increased iodine.
Have any of you guys had iodine supplements before?
No.
One?
What would that be used for? Taken for? I mean, besides that, that's the only reason. Okay. Then.
So when I ask, has anybody received iodine supplements before? Everyone in this room should raise their hand.
We don't get it.
What did I hear?
Salt? Are we all deficient?
Salt. When you read the packet of salt, what does it say on the salt? Iodized salt. So, a little history lesson way, way back when. There were tons of people who had hypothyroidism. They studied hypothyroidism and found out we need a major building block of thyroid hormone. Major building block of thyroid hormone is iodine. So they sat and they thought, how do we get people to eat more iodine? Because they're not going to sprinkle it in their food. It has no benefit and no taste. What do we sprinkle a lot in our food?
Salt.
Salt. So they mixed iodine in with salt, and now all of a sudden, a huge number of people who did have hypothyroidism no longer have hypothyroidism.
Now we got hyper.
So it was because of the malnutrition in iodine. So hyperthyroidism, no, we have a society of a lot skinnier people.
Interesting.
What we have is what we call euthyroid. It's going to be a test question in summer.
EU.
Phyroid. Euthyroid. What does that mean? What's the difference between euphoria and dysphoria?
Isn't euphoria pleasure?
Euphoria is like everything's good.
Good.
Yeah.
Everything's great. Everything's working how it should.
So,
Dysphoria means it's not working. So what is euthyroid?
A good
isn't
thyroid.
it? Yeah.
Is a thyroid that's working normal. Remember this for summer.
Okay, so it's just
I know it's there. I've
Can you
seen it
spell
with
it
my
out?
own eyes. Huh?
She
Can
did.
you spell it out?
Euphyroid. Euthyroid. So I tell you, when it comes to medical terms, knowing medical terminology is going to help you guys a lot. Okay, so increasing iodine in the diet. Giving medication, I heard levothyroxine. I also heard vitamin D. Vitamin D is important for metabolism and our immune health.
can't you get that from the sun, right? D?
Yes, some people's skin isn't too great at making vitamin D. They allege that if you have 15% of your skin exposed for 15 minutes in the sun, you make all the vitamin D you need. But all in the summer change ethnicities, and I still don't have enough vitamin D. So sometimes some people's bodies just aren't good at making it,
Yeah.
so they have to take it as a supplement.
And then,
I'll get real dark in the summer.
so I'm guessing then vitamin D would be good to take
I
during
have a
the cold.
couple swimsuit tan lines just from this past weekend. But even though I do that, and I drink a lot of milk, and I take supplements, when I get my vitamin D checked, I'm still low.
Unless you say
Wait.
from
I don't do tanning. When I was younger, I did.
Yeah.
When I was in nursing school, I would listen to my lectures, and I'd ride my bike from where my dad lives, because I lived with him at the time. I rode it down to downtown Redlands, which is about 10 miles. Then I would go tanning for the half hour. Then I'd ride my bike back up, listening to my lectures, and that was both my exercise, plus my vanity, plus my study time.
Time efficiency.
Boom. I obviously don't ride the bike anymore, but
I need a
that's
bike.
besides the point. So, we're going to give thyroid hormone. Now, really, when it comes to thyroid issues, there's not much nursing care we can do. It's because we've eliminated the diet by putting iodine in the salt. We've eliminated that. There are some things like teaching the patient how to assess their skin and nails. Teaching the patient that when their heart rate goes too high, that's a sign that we're over medicating them. Because now their body processes are going too fast. What about if they dramatically lose weight? That's another sign that the medication we're giving is too high. What happens if they have rapid weight gain?
Not enough?
Not enough. What if their heart rate's too low?
Not,
Not enough. So we can do teaching. We can do administering.
isn't hypothyroidism like kind of genetic or no?
That I'm not sure on.
Because like, I feel like a lot of people like they're usually like they either have it or you don't. Like I've never heard of anybody like develop that. They usually say like, oh, I was born with
I've had
something.
people develop it. I've known people who have developed it later on in life. Sometimes animals can develop it too. So it can be developed. Same thing with any of our hormones.
Yeah.
If we end up with a hormone imbalance, let's say for example our adrenal glands stop producing. That could be Addison's disease. So like any of the hormone issues, if they become imbalanced, like I know a big one right now for ladies is PCOS, polycystic ovarian syndrome. And that one causes like weight gain, and it causes like facial hair, and it causes horrible cystic acne. And those are related to the sex hormones getting thrown off. But PCOS is something that can develop just like any of the other ones. So to say it's a familial thing, not necessarily, but I do know people who have like Graves' disease or hypothyroid where it can be inherited. So it could really be both.
So it's basically like it's like a mixed bag kind of.
Yeah.
Okay.
Like to say, you're going to have hypothyroidism and you're not really, unless you have like the genetic mutations that cause Graves' disease.
So that's where you'd look at like family or history and whatnot.
The what?
That's where you would look for like family history, right? If they have like parents and stuff that have it.
Yeah. Now I know a girl who has Graves' disease, but her parents don't. She was just born with it, and they found it out pretty early on. My niece has a hormone issue with her adrenal glands, and her parents don't have it, but it is an inherited thing. So with my niece, it's a recessive. Neither of the parents have it, but the two parents had to pass the genes on to the kid. So we always make a joke that my sister and her ex were like long lost cousins, because for the odds of two people with both those recessive genes to make one child, because it's like crazy rare, the type of genetic issue my niece has. So like we make some joke like, haha, they're inbred basically. We're savage to the nieces. If you think I'm savage with you guys, these kids got no, I mean, they're, good luck to them. They're going to have thick skin.
Can you get it from stress too?
You can get the adrenal one from stress, yes. Because that works on our cortisol, which is our stress hormone, the fight or flight. So yes. Thyroidism, not necessarily stress. Okay, so now let's look at the list of nursing diagnoses. Let's try to figure out which one of these would be best for their patient. I would say definitely risk for falls because he jacked up both legs somehow.
Oh yeah, 26.
But
would
but that's not related to hypothyroidism.
would number 12 be reasonable? Decreased cardiac output?
So decreased cardiac output. If we saw his heart rate being too high or too low, yes, that would be a problem. But right now the heart rate's normal because the medication's doing its job.
Okay, so right now that's...
So don't quite see that as a problem. Now, what did he do? He jumped off a roof to
like
break
a
his
two-story
legs?
balcony.
Yeah.
A two-story balcony. Who here has jumped off a two-story building before?
No.
Be honest.
You did it.
I
would love to
sure
jump
know I
before.
have. When I was a wild kid, and we used to we lived near an elementary school, and we used to climb on the roof of the elementary school, and there was this old bat across the street. I'm gonna call the cops on you. So what do? We jumped off the roof and ran away. So, did I break my legs?
No. I'm assuming no.
Maybe.
No.
But it hurts.
I've never had a broken bone.
But it hurts when you fall.
fall.
Oh, it hurts. Oh, for sure.
I think it depends on how you land, because you could roll, or you could just like go like.
Oh no, the feet hurt.
Yeah.
Usually,
said he tried to roll.
you'd fall like on the hands
I
and
think it
knees,
was
like
a-
because
the
the
roof
force.
of the 2-story, not the roof.
But
I always roll.
for him, he's in this facility because he broke both legs. We talk about thin hair, brittle hair. Don't you think that can also be related to
Broken bones.
the bones?
So broken bones can cause brittle hair.
No. But because the patient has hypothyroidism, their metabolism isn't good, meaning their body isn't rebuilding how it should, meaning it's not building hair appropriately, it's not building nails appropriately.
He also has muscle
What is it
atrophy.
doing to the bones?
It's probably.
Is it building the bones appropriately?
No.
So do you think maybe the bones are brittle too because of the hypothyroidism?
Oh.
And you think maybe a person who would normally not break both feet jumping off a 2-story building?
Yeah.
See where I'm
Looking
kind of
glass.
tying this in at? So let's look at his nursing diagnoses when it comes to maybe broken bones.
Risk for injuries?
But is he a risk? Oh, he's an active problem. He's not a risk anymore.
Risk for.
Now let's say before he broke his bones, yes, he would be a risk. Now that the bones are broken, damage is done.
So would it be, could 49 be? Because we need more iodine, right?
So 9,
49.
oh,
Because
49.
like he would need more iodine, right? So. Or is it 49 or 50?
49, imbalanced nutrition less than body requirements.
Or is it 50?
Yeah.
Not 50.
So it was 49. Okay. So I'm trying to think.
Or 47. Impaired physical mobility.
So what about 47?
Yeah.
So we think about risk of injury. We're not preventing anything anymore.
Impaired mobility.
We have 47. Impaired physical mobility. That's a good one.
I made another orphan movie.
Hmm?
I made another orphan movie. It was just on here. It went away.
Oh.
One of the ads.
Impaired physical mobility related to
Lower metabolism? Or no, decrease in thyroid.
Decrease in thyroid.
decrease in metabolism
As evidenced by.
due to decreased thyroid hormone. As evidenced by, what evidence do we have of his physical mobility?
Wheelchair. Walking boots. Waiting.
Bilateral broken legs. Walking boots.
He also got the wheelchair.
Wheelchair bound. Cool?
Boom.
Don't get me in your pictures.
Alright.
I'm not a fan of pictures. Please don't. Please don't.
What's good?
So I couldn't print our first one, but I have
Here, I need those. You want to like peek at it?
Yeah, I mean, all the info is here, and this is just the personal.
Get out.
Okay, that's fine.
Speak up for us.
As long as you're able to like convey the info. Okay.
You guys got rock
Let me restart the timer.
It's only fair. It's only fair.
The president is gonna talk now.
Okay. Are we ready to help them out?
Yeah, yeah.
How are you gonna change our lives?
Whoa.
What time is the thingy? 11?
Yeah.
What type of policy?
Oh, yeah.
All right, let's start.
Okay, so our patient is a 60-year-old male, and his diagnosis is benign prostatic hyperplasia, and he also has a UTI in the lower urinary tract. So he's gone through dialysis, and he has a urinary catheter.
For his vital signs, his temperature was 98.4. His pulse was 53 beats per minute. Respirations were 16 per minute. And his blood pressure was 95 over 65 when we checked. And his pulse oximeter was 97. Patient was fully conscious and aware of his surroundings. For his orientation, he knew who he was, the time, the place, and why he was at the facility. And for his emotional status during assessment, he was calm, but his usual status, he's distressed since he has depression. Also for his speech, the patient was clear, coherent, and communicative with his words. Both of his eyes were equally reactive, and the sclera of the eyes was white and clear. For his ears, nose, and mouth, his ears and mouth were pink and moist, but the nose was dry and we were able to see visible cracking. For his skin, he had partial mottling, and he had an open wound on his right shin, the tip of his feet all the way to his ankle, and he had an open wound on both posterior thighs and an open wound above his sciatic nerve, and patient had no pitting edema. His heart was faint, but he had a regular rhythm. For his lungs, we checked all locations, anterior, posterior, upper, middle, and lower lobes, and it all sounded clear, and patient has no trachectomy or how do you say it? Tracheostomy.
Oh, tracheostomy.
Tracheostomy.
Oh, trachectomy. What's
Yeah.
that? What's the trace? Why are we ectomying it?
And patient had no colostomy or G2 placement, and his abdomen was symmetrical with no distension. Bowel sounds were present in all four quadrants, and he had a couple of scars. For his extremities, he was able to move most of his limbs. He was able to move both of his arms. However, he wasn't able to move his left leg. It was limited for range of motion, and it was also he had contractures.
Contractures.
Yeah.
Where the
And he had neuropathy on both feet, and his left leg had length discrepancy. Also, for the equipment, he sometimes wears like an oxygen mask, but not all the time. Only like when it's necessary for him.
So, for the Foley catheter, he says his output is an average of 1400 cc, and it's a clear color. So the medications that he takes a lot of medications, but the main ones are sulfamethoxazole entrimethoprim, which is an antibacterial, and that is to treat the UTI that he has. He also takes phenazopyridine, and that is to an analgesic. It relieves the pain of the UTI when he's urinating. He's taking tamsulosin hydrochloride, and that is for the benign prostatic hyperplasia. It helps to what's it called? It helps reduce the swelling so that he can void more easily.
So that one, just real quick, that one, the tamsulosin is also known as Flomax, and what it does is it relaxes the smooth muscle, which allows the urine to come out. Yeah.
And then he's also on nitroglycerin for angina, because he has chest pains.
Okay, for the textbook pathophysiology.
Not the same thing as what you guys are thinking. Angina is not the same as vagina.
I legit was not thinking.
No, I saw all the back boys were all.
Yeah.
So angina is another word for like a pre-heart attack. Kind of not funny.
What is it called?
So for the textbook pathophysiology,
It's a
benign prostatic
cardiac.
hyperplasia is a chronic disease that progresses in aging men. And in aging men with benign prostatic hyperplasia, they will get an enlargement of the prostate, resulting in narrowing of the urethra, and then it reduces the urinary flow. Benign prostatic hyperplasia treatment consists of medications that will relax the muscle in the prostate to relieve symptoms, medication that will relieve the pain caused from BPH, such as digoxin, taurulicin, and tamsulosin, which is or an invasive procedure such as a urinary catheter or a prostatectomy. I don't know how to say that.
Prostatectomy.
And for the textbook nursing care management, all I was able to find was that it said to give the client warm showers so they could relax their sphincter muscles, and warm showers will like allow the urethra to widen, and it will make it easier for like the patient to void. Also, another one is like an insertion of a urinary catheter and monitoring the catheter for any abnormalities in the output of the patient, and also administering medication to ease the pain of the patient. And then the actual medical/surgical treatment is like the medications and the Foley catheter and has gone through or having a. Oh yeah, for our patient, he had a Foley catheter, and he was undergoing dialysis and still is. Also, the patient.
Oh, for the actual medical and surgical treatment that he's getting, he's been getting an anti-infectant for the UTI, which is the Bactrim DS. And then this is paired with a peripheral analgesic, which is the pyridium. And then he's also receiving anti-adrenergic drug, which is the Flomax.
Okay. So when we look here at the causes of what BPH are, The prostate gland is located beneath your bladder. It is a tube that transports urine from the bladder and out of the penis, which is the urethra. And it goes through the center of the prostate. Do women have prostate glands?
No.
No. But when the prostate begins to enlarge, it blocks the urine flow. Most men have continued prostate growth throughout their life. In many men, the continued growth enlarges the prostate enough to cause urinary symptoms or to significantly block urine flow. It isn't entirely clear of what causes the prostate gland to enlarge. However, it may be due to changes in the balance of sex hormones as men grow older. What are the male sex hormones? Testosterone. So, as men go older, their testosterone level drops. So, what could be another medication we can use? So I talk about my dad, right? I mentioned my dad was getting his knee surgery, so he stopped all his meds, including his testosterone gel. Then he's telling me I need to go talk to the doctor about why I'm peeing so dang much. Well, did you resume your testosterone med? No, it's been like 2 weeks since I took it. How about you start taking that again? Hopefully it will shrink the size of that prostate and then you'll be able to pee normally again. Okay, it worked. Now this patient I didn't see was on testosterone therapy. He had more invasive measures. So maybe he tried testosterone therapy and it didn't work. Then he had to get started on Flomax. He's on Pyridium to relieve the pain. He had a urinary catheter inserted. I don't think he had the surgery, the prostatectomy.
No, he didn't.
Now, when we think about going to the bathroom, and we gotta go, let's say we're in the shopping mall and we have to pee real bad. What happens when we walk near that fountain? When we hear water running, that triggers our mind like, oh, now I really gotta go. So warm showers, running water, just the sound of it.
Yeah, don't they like sometimes leave the faucets running?
Mm-hmm.
Yeah.
If you have a patient that's having a hard time going to the bathroom, turn on the faucet, let it run. That sound is going to make things want to start flowing. Warm showers, yeah. But his main issue is being not able to pee. So, what happens when we pee? What happens to that urinary tract? It gets flushed out. The bacteria gets washed away. If the patients aren't able to pee appropriately, what happens to that urinary tract? The bacteria sits and it gets infected. That's why they teach ladies, especially because we have short urinary tracts, to pee before and after sex to flush out the bacteria that we may be getting from our partner. So we can do warm showers, running water. Now we can even put the patient's hand in warm water. Another thing we can do is something called Crede's maneuver. I don't think I spelled that right, but this one's right. Now this one, Crede's maneuver, you may see on a test, and what Crede's maneuver is you take your hands and you almost palpate the patient's bladder, pushing the urine down. And it should help create pressure enough for them to void. So let's look at these things that we can use to treat benign prostatic hyperplasia. And let's figure out which ones a doctor needs to do and which one's a nursing care. So testosterone replacement. Flomax medication.
Okay.
Peridium medication. Inserting urinary catheter. Doctor will order it. What about monitoring urinary catheter? Nursing care. Prostatectomy. Cutting the prostate gland out. Warm showers. Nursing. Running water. Nursing. Hand in warm water. Nursing. Credes maneuver. Nursing. Now I wrote the word TERP. What is that? Men, are you ready to clench up?
Nah, I'm good.
So a TERP is called a transurethral prostate resection or resection of the prostate. What does that mean? So transurethral means through the urethra. Resection of the prostate means we're taking pieces out.
Oh yeah, I heard about that from one of our instructors.
So what that is, you know how like we call up Roto-Rooter for our toilets when they're clogged?
So they go through
And they go through and they grind up
Oh.
and eliminate blockages. Well, if our prostate's blocking, they go in through the urethra, Roto-Rooter and grind out the prostate, and now we have a clean tube. Yikes. Who wants that one?
Chase.
Yeah, I know.
Andy's ready for anything and everything.
You're out your mind. Are you sure you're going to be working at Patton?
I swore I would.
So, believe it or not, there is a client over at Patton that was a former student.
That's interesting.
Yeah. He's
What
actually in
happened?
this classroom
What
right
if
now.
that's
His name starts with a C.
C.
No, for real though, there is a former student of this program as a client at Patton. Yes, way.
Yahweh?
Yahweh.
Yeah.
Okay, so let's bring it back together. So let's talk about this client and let's look through the nursing diagnoses to figure out what kind of nursing diagnosis is most appropriate for this patient.
74, urinary retention.
74, urinary retention. Cool. What about 59?
Eating. Oh, bad. Bathing.
Bathing, hygiene, self-care deficit. So let's say you were a patient that had a urinary catheter in. How comfortable would the average person be dealing with that catheter?
Probably not.
Some people may feel comfortable, some people may not. I think that would be a good one. What about, acute pain?
59.
Definitely when they're putting it in. Now, what happens if a patient had a urinary catheter for a long period of time? Do they feel it?
No, I wouldn't think so.
Pretty sure they get used to it at some point.
Do you guys feel the clothes that you're wearing?
Yes.
Yes.
Do you guys cognitively think of your clothes all the time?
No.
Why?
Because we look used to wearing
Your
clothes.
body adjusts.
Because your body adjusts. Your body feels that stimuli. Think of if we did feel our clothes. Don't you think our brain would be overwhelmed with the sensation?
Yes.
So what does our brain do to nerves that are constantly stimulated?
And nurse them.
Shuts them down. So when your brain shuts it down, it's kind of blocking out too much information. So eventually the pain of a urinary catheter will go away. Now let's look at 40, 41, and 74.
He already has an infection, I thought.
Hmm?
It's 42.
40, 41. So 40 we have functional urinary incontinence. 41 total urinary incontinence.
If you have a catheter, doesn't that mean like it is good for you?
You are kind of technically incontinent because you are not able to control your bladder anymore.
Yeah.
You can't hold it in. Now, what's the difference between 40 and 41? What is incontinence? Not when you can't pee. Uncontrolled peeing. So you can't hold it. So what's the difference between 40 and 41?
Isn't it that functional, meaning that it's you have some control as for total urinary incontinence, like you can't control it at all?
Yes. So, an example of functional urinary incontinence would be, have you ever heard of a lady who's like, oh, I just gave birth and now I can't laugh too hard because I'll leak a little? That's because when the baby comes out, it weakens those pelvic floor muscles. So now it's harder. Well, you gotta do Kegels. I know. Number one, don't jump on the trampoline and do your Kegels. No, actually, even though it sucks, but jumping on the trampoline would help those pelvic floor muscles to strengthen. Now, let's say the baby was huge and it went through and ripped and destroyed a lot of those muscles. What can that do to either the bladder or the uterus? Is it going to hold them up in the body? They can have a condition called prolapsed uterus, where if they push down, you see the uterus come out through the vagina. I've seen that quite a few times, and it's like, oh, it's shocking. Or the bladder. Both of them are very shocking. So, what's important? Do your Kegels. Even for men. You guys should keep your pelvic floor strong. Okay, so let's bring it back to the patient. So which NANDA nursing diagnosis would be best for this patient?
You can't control it.
Oh, yeah.
Yeah, the first one. Or 73 is
Can't control it at all. Yeah, 41 would be.
So
Yeah.
which one would be best for this client? 73 or 74? Impaired urinary elimination or urinary retention?
73.
I think impaired 73, right?
How come 73?
I thought they can. Or no, they can't. I forgot.
73 or 74? Now the patient has a catheter in. So are they retaining?
No, no.
Not anymore.
Not anymore.
What about before the catheter?
Yeah.
74 would be best for
So
this
at this
patient.
moment it's 74.
So at this moment is 73. Before the urinary catheter, 74. See the difference between those?
I was wrong.
So we'll do impaired urinary elimination. Impaired urinary elimination related to what's our related to? So we can elaborate on this further, because what does an enlarged prostate do to the impaired urinary elimination? So we can do enlarged prostate constricting urethra, or the urethra. Then we go as evidenced by. What's our evidence that urinary elimination is impaired?
Urinary catheter, enlarged prostate. Enlarged prostate isn't a diagnosis.
Benign.
Benign.
Yeah. Oh, let me go right now.
Okay, so as evidenced by urinary catheter needed to void. What does void mean? Pee or eliminate urine. So that would be a good NANDA nursing diagnosis for this patient. Yeah?
Yeah.
Cool.
Let's take a picture of that.
Yeah.
Your Excellency.
October 20th? What day is that? Friday. Right? Oh, Thursday. Thursday next week. We're at the new facility.
Let's go.
Thursday next week, they're doing the American Shakeout. So that's this Thursday, next Thursday. So those who are with me at Anderson, we might be able to help evacuate those kids. Yeah, we're gonna have a lot of work that day. Just so you all know. Run! And they're all in the wheelchair. They can't run.
You don't got legs, use your arms.
Okay, so I was actually talking about one of. Is he in the bathroom again? Dude, he
Bowel
needs
syndrome.
a Foley catheter. When he comes in, who has a bow? Does anyone have like a bow or ribbon? I need like the Friday. I'm gonna hand him a catheter, like with a bow on it. Here you go.
I'll hand him the one that we use for practice.
It's gonna be one of those. One of those. Okay, let me restart my timer. Just introduce.
Alright. Whenever you're ready.
Okay.
Alright, so for the part one of this assessment, we got an Asian female who's age 58. She's her classification of diagnosis is malignant neoplasm of the pharynx and then malignant neoplasm of the tongue. So it's a cancerous of the trachea and the tongue. Alertness, somewhat. Allergies, unknown. The overall physical and psychological description is that the cancer of the tongue and the throat leads to a protein calorie malnutrition, anxiety disorder of the current events, and local infection of the skin and subcutaneous tissue, dysphagia, insomnia, localized swelling, mass of the lump in the neck, adjustment of the gastrointestinal appliance. So, the past surgery of the medical procedure, she has cesarean section in 1989 and appendectomy at 11 years of age, 11 years old.
So her vital sign, temperature was 97.5, pulse was 85, respirations were 22, blood pressure was 140 over 98, and then her oxygen saturation was 98%. She was fully conscious. She did say she was sleepy because she had just gotten back from chemotherapy that day, but for the most part, she's fully conscious. So she was alert ×4.
with person, time, place, and situation. Her emotional status, she was very cooperative, was able to answer all our questions. She did state she was depressed due to her living situation at the nursing home, and she was fatigued because of all the medical procedures she has done. She did state she was anxious for us to do any treatment on her just because we were students, but she did let us look at her G-tube and do the assessment on her. So her speech was clear and coherent. Her pupils were reactive and equal. She did have a dry mouth just because she said she was dehydrated, so they did put her on IV fluids.
IV?
Huh?
They put her on an IV?
Yeah.
Mhm.
Oh, okay.
Yeah,
It's
this
probably-
week or last week she was on it.
It's probably because all the meds that we went through. Because she did have a lot of meds.
Well, plus she's not allowed to eat or drink technically because she has that mass.
Oh yeah. So,
Yeah, so she did also have crusted secretion on her lips, so her lips were all dried. Her skin was intact, and then she did not have any pitting edema, and her turgor was poor due to the dehydration. Heartbeat was regular, lungs were clear and regular. She did not have a trach. She did have a symmetric and active bowel sounds. She did have a G-tube placement, and it was intact, clear, and dry. The dressing was also intact and dry. There was no drainage. And then she had full range of movement. Oh, sorry.
Oh, sorry. And, school development.
Yeah. Or do you want to do that?
Oh, I can do it.
Okay.
So for the equipment would be the gastrotomy, and the gravity feed would be like the G tube and everything. The side of condition was pretty normal. So far she's pretty like to work with us when we do the G tube and everything with the gravity feed. So yeah, our summary findings is that the cancer has led to unable to eat, and now she has a G tube, and she's been taking all her nutrients in her stomach. So part
You all right
3.
over there?
Yeah.
Do you want me to do anything or the one that I did? And then you can just
Yeah, sure. Yeah, actually I wouldn't know. I guess.
So pathophysiology, so we put that the patient has a cancerous tumor. That means so the mass in the body was spread into the tissue, and this happens because there is a change in her DNA, which sends signals to the cells. So for example, one thing that can happen with cancer is the cells change. So when they change, they ignore the signal to stop reproducing. They just keep growing, or they stop dividing. And then for the textbook treatment, there are multiple ways to treat cancer depending on the situation. So it can be treated through surgery, radiation, chemotherapy, or hormone therapy. And then for care management, for nursing care management, the nurse mostly assists after the surgery to make sure there's no infection or the stitches aren't ripping. And then pain control, making sure that the patient has a healthy diet, and most importantly, emotional support to deal with the cancer treatment.
So for the surgical treatment, so the surgical treatment is the patient is undergoing chemotherapy in response to the cancer of the tongue and the throat. Patient attends the chemotherapy twice weekly to reduce the thing, and then describe the actual medical surgical process. So for E, I put nursing treatment involves laxatives and other stool softener to be administered in the response of constipation as a result of the chemotherapy. And mouthwash is also administered 3 times daily to keep the cancerous site clean.
Did you want us to read all the medications? But she had like close to 20.
Yeah.
Just do the ones
The important
for,
ones?
yeah.
So one of them that we had was Lomotil. So this is used to treat diarrhea by decreasing the number of bowel movements. So the recommended dosage is 5 milligrams, but you should not exceed 20 milligrams daily. So side effects are drowsiness, dizziness, headache, tiredness, blurred vision, dry mouth, and loss of appetite. The nursing responsibilities. So if the patient has glaucoma, you should not give them this medication because it dehydrates them. And if the patient has an opioid allergy, also you should not be giving it to them. And you should monitor any liver, abnormal liver function. And then you should teach the patient that if they're under 13, they should not be taking this, and take with a full glass of water, and drink fluids throughout the day because it helps replenish the fluids from the medicine that dehydrates them. The other one that we did was Imodium. So this is treats diarrhea or IBS. So adverse effects are chest pain, decrease in urine output, hives, welts, rashes, and irregular heartbeat. The nursing responsibilities is to assess the fluid and electrolyte levels, monitor heart rate, and it could lead to constipation. Patient teachings: take with a full glass of water, also take with a lot of fluids. Do not take this with alcohol, and this pill can be taken whole, in pieces, or crushed.
And for the other 2 drugs, hang on, just my printout's so stupid. Yeah, you guys can just listen. So the next drug is called Procom. It can treat nausea and vomiting. It can also treat anxiety and schizophrenia. Usual dosage is 5 milligram orally 3 to 4 times a day. No more than 20 milligram a day. The adverse effects of this would be dizziness, feeling unsteady or having trouble keeping your eye balanced, blurred vision, dry mouth, and stuffed nose. So nursing responsibility is to watch signs for agranulocytosis and leukopenia, including fever, sore throat, mucus lesions, and other signs of infection.
So that word agranulocytosis means it means that less red blood cells and white blood cells are being produced and let go by the bone marrow. So you'll see blood count levels on the lungs drop.
Oh, okay. And then for patient teaching, avoid driving or hazardous activity until you know how this medication will affect you. This medicine may cause dizziness and blurred vision. It may impair you to react. Dizziness can cause falls and accidents of severe injuries. And other medication. Jesus. The other medication is Zofran. It can prevent nausea and vomiting. Usual medication is 8 to 24 milligram given a single dose before a chemotherapy. Maximum dosage for the adults is 24 milligram a day, so do not exceed that. Adverse effects are headache, lightheadedness, dizzy, drowsiness, tiredness, and etc. The nursing responsibilities are assess dizziness and drowsiness that might affect the gait, balance, and other functional activities. Report balance problems and functional limitation to the physician. And then for the patient teaching, so kind of look out for, are also using apromophene. Do not take this one using apromophene. Your You are allergic to ondansetron, to similar medication. To make sure ondansetron is safe for you, and tell your doctor if you have liver disease or an electrolyte imbalance, so low level potassium or cognitive heart failure.
Cool.
Cool.
Alrighty, so their patient had cancer in the mouth, which made it impossible for the patient to eat, because now she's getting radiation, which causes pain, and she's also getting chemotherapy. So radiation is almost like they're taking a microwave and zapping the cancer to kill it. So there are such things as like laser therapies and stuff too that weren't mentioned up in there. But when it comes to radiation, it's almost like they're burning those cancer cells away. So even if they burn that mass away, it would be pretty painful for the patient to eat. So one of the big things she's getting is G2 feeding and feeding by gravity. So she's the one, if you guys saw her, she has like pretty big eyes, they're brown, very like wide-eyed, she almost looks like shocked, and she's very, very cautious. So, you know, for her, she speaks fine. She gets the mouthwash to help reduce any bacteria from that radiation burn inside the mouth. So it's either we let the mass continue and it can spread to other areas, or we gotta burn it away with radiation and kill it with chemo drugs. So for her, she's getting G2 feeding and all that. So what would be a really good nursing diagnosis for her?
I saw it just a second ago. Is it the nutrition? No. It's the facts.
So she has malnutrition, right?
Yeah.
So we have, in related to nutrition, number 49 and number 50. So we have imbalanced nutrition less than body requirements, or imbalanced nutrition more than body requirements. What's the difference between those two? So,
I have a question.
Uh-huh.
With the G2, doesn't she get enough nutrients? Because like you said, we can
So she gets, I'm trying to think of what her formula is.
It was the one in the little carton.
Yeah, but
They're like some supplements.
was it Jevity? Okay. Regardless of what formula type it was, I know for certain we have 1.5 cal per ml. So 1.5 calories per ml, and the bottle volume was 238 mLs. So how many calories is she getting from that?
Like around 500,
For
500, I think. Yeah.
Let's do the math. Is that
I'm not trying to.
basic math I'm not good at.
what is 68?
Throw me trig, throw me. No, I never did like what do they call it?
I don't know.
1.5 times.
500. That's a little bit. But it depends on how you. Yeah, that's a little bit.
How many times a day did she get this?
Like 2.
Twice.
3 times.
Twice with us, probably 3 times.
Sarah. Sarah.
Yeah, so I'm only getting 2 bottles.
So times 3.
That's not a lot.
Eats normal food too, right?
How many calories do we typically eat in a day?
Almost like
1,500.
Should be hitting him.
Oh, really?
If we're on a diet, 1,500.
That's
When you look, who has like any sort of drink or whatever?
I have water.
It doesn't have nutrition facts.
No, it's just water.
Who has something with nutrition facts on it? Like a protein shake. Okay. On
We don't
that,
taste it.
on those chips, of course. On those chips, when it talks about the vitamins and minerals on there, what it says recommended, it says percentages based on a recommended blank calorie diet. 2,000 calories is what the food companies document as our average daily intake. Now, when we talk about 1,500 calorie, 1,600 calorie, 1,200 calorie diets, that's because we're actually trying to get the patients to lose weight. So those specialty diets, when they're ordered a certain calorie limit, is for specialty diets. But per our daily recommended, the average person should be taking in about 2,000 calories a day. So when we talk about the patients receiving 1,071 calories a day, even though she's getting G2 feeding, is that enough? No. So when we come here and look at this imbalanced nutrition, less than body requirements or more than body requirements, which one fits this patient the best?
less.
Less. Impaired nutrition, less than body requirements, as evidenced by, related to,
Related to.
sorry, good catch, related to,
Malignant neoplasm.
so if we wrote malignant neoplasm on there, is that a medical diagnosis?
Yes.
Ooh, tricky.
Just cells.
So we just write kind of like the general view, not the medical doctor.
Yep, exactly. Now we could say from changes in DNA, basically kind of stating. So what we're doing here is we're taking the medical diagnosis and simplifying it. Because if we look at malignant neoplasm, do we know exactly what malignant neoplasm is? No, but do we know what an overgrowth of cells in the oropharynx is? Yes. So we're kind of putting it in nursing terms. Okay, as evidenced by. What is our evidence that she's malnourished?
Her feeding.
G2.
G2.
What about her weight? What was her weight?
I think we did not get that.
Okay,
Get it.
that's all right.
Okay.
What was her skin turgor like?
It was slow.
Skin turgor was really slow. What happens when people have dramatic weight loss? What happens to their skin?
Dehydration.
Get loose.
Their skin gets loose. So that skin turgor is probably poor because she lost weight. Right?
Yeah.
That is also evidence that she's getting less than body requirements nutrition. Now, if you guys do get her weight, and you see what the admission weight is to what the weight is now, you guys can add that in as your last one.
Okay.
So you just basically compile all the evidence that proves they had less than body requirements. Cool?
Yep.
Thank you.
Thank you, sir.
Now we have 2 more groups still, right? Okay.
You know that page where we
Oh
I
yeah.
think it might be in there somewhere.
Yeah, right?
Yeah, it probably is.
Okay.
It's at least should have like an admission rate
Okay.
on there.
Andreas, I'm gonna grab your packet, okay?
Oh
Is this
yeah,
your pen?
thank you. Yeah.
Okay.
Yep. Got it. I'm gonna airdrop it to the Discord.
Thank you.
My eyes, my nose.
Ready?
Yeah.
Let's go.
Okay. So we.
Let's pay attention. If we want everyone to have a fair chance.
Okay, so we have a 62-year-old man. So he is a post-op patient. He got surgery on his, I think it was his lumbar 3 and 4, right? 4 and 5, my bad, 4 and 5. He had other diagnoses like pneumonia and COPD, but we're focusing more, I guess, on surgery, well, the side effects from it. So for his assessment, his temperature was 98.3. His pulse was 70 beats per minute. His respiratory rate was 20. His BP was 128/78. And his pulse oximeter is 97%. His consciousness, he's fully conscious, very aware. Orientation, he knew where he was at, why he was there, and who he was. Emotional status, he was cooperative. Didn't really show any sign of depression or anything. His speech was very clear. For his eyes, they were reactive. His pupils, his sclera was white. Her ear, nose, and mouth, we didn't see any secretions or any abnormalities. Sorry, but he didn't have teeth. That was one thing we did see.
Dude, you wanna know what's kind of sick? I had a patient yesterday, 42 years old,
No teeth.
no teeth, dentures. Oh yeah,
Was
carry
it a
on.
guy or a
It
girl?
was a guy. No, thank you.
Yeah, he had no teeth. But his gums look good. They look healthy.
Sparkling gum.
His skin was very moist. Wasn't dry or cracked and stuff. For his heart heart rate sounded regular. His apical pulse was a 56. For his lungs, he did have some wheezing because he's a smoker. So due to smoking, he would find. What else? We didn't find any secretions. His abdomen, his bowel sounds sounded active. He did have some tenderness though on his stomach, just a little bit. For extremities, he was able to move his arms and his legs. And what else? But we did see his incision on his back where he got his surgery. And he does not use any equipment. So for his what is it? Sorry, I'm trying to think. My brain's all foggy right now. So for his treatment, he told us that he did get physical therapy, and he is 4 months post-op. He said he got it in July. He said that it took him about 2 months to be able to walk on his own, but he did need a wheelchair. For his medications, a lot of pain meds, but we have the 4 that we focus on, which is dialclofenic sodium gel. I don't know if I said that right. It's applied on his lower back. It's an anti-inflammatory. He also has cyclobenzaprine, which is by the mouth 3 times a day for his muscle spasms. He also takes GABA, thank you. Gabapentin, which is the capsule, by the mouth 3 times a day, which is an anticonvulsant medication. Did I skip one? Yeah, I did skip one. Sorry. Which one? Oh, never mind. This one. And then for his last medication, he takes baclofen.
Baclofen.
Thank you. Baclofen tabs by the mouth 3 times a day for muscle spasms as well. For our nursing responsible, not ours, but in the facility, responsibilities would be to check his vitals, also to have him rest, not making him do too many activities. Another thing would be also to assess his mental status and behavior and monitor his symptoms. And then, go ahead, Rocco.
Okay, so basically the patient got into an accident which required the patient to undergo the spinal fusion surgery within the L4 and L5, which is a surgery to permanently connect the 2 or more vertebrae within the spine. It involves the bone graft, which is a technique of using bone-like materials such as metal plates, screws, and rods within the space of the vertebrae to hold them together so that they can heal into one solid unit. So like for the pathophysiology, immobilizing a section of the spine places an additional stress and strain of the area around the fused portion, which then causes the muscle spasm and the back pain. So muscle spasm is persistent involuntary muscle connections, and the main reason for the cause of pain for muscle spasm is because of the muscle ischemia, which is a blockage of the blood flow to the heart, which causes inadequate blood supply to the organs. And for the textbook nursing care management would be patient monitoring, such as like checking the vital signs and wound care. For the surgical sites, pain medications and muscle relaxants are needed for pain management. He also needs to undergo the physical therapy and occupational therapy so that he can continue like his daily living and be able to walk again. And so to describe an actual medical and surgical treatment, like I said, he has like spinal fusion where the bone grafting occurs to provide stability of the spine while the new bones are created and healed. So
Yeah.
yeah, that's about it.
Okay, so for this patient, he required a spinal fusion. That's where we bond together the vertebrae. And when the vertebrae are bonded together, they no longer move. Either way, back and forth, up and down, they're just frozen there. So, as with any muscle, including our muscles in our back, if we're unable to move the muscles, what happens to those muscles?
They begin to atrophy.
They atrophy and they can also tense up. So, people who are very flexible, if they don't maintain that stretching, what happens when they go back to try to stretch?
We can't stretch like they used to.
Can't do it. So like people who did gymnastics when they were younger and they were able to do the splits, then they stopped attending gymnastics lessons and they go back to go do the splits and they're like, oh no, I can't. They have to use it again and try to loosen those muscles up. Same thing can happen to the muscles in the back. So if the muscles in the back are no longer able to move, then they stiffen up and they reduce mobility. So you're talking about these, right? Impaired physical mobility? That's where you were getting at. Now, did someone have impaired physical mobility already? You guys, huh? We use that one for you guys, so we're gonna pick a different one for them. Because I want everyone to have a different one. So, one thing that we can do to kind of help that muscle spasm, because they're no longer able to stretch, even if they had if they didn't have a spinal fusion, how can we stretch the muscles in our back?
Can you like hang off?
Touching your toes.
Touching our toes stretches our back.
Can you like hang off of stuff to like stretch your back?
Some people will hang off of things like with their arms, or they'll do by their ankles an inversion table. There's that too. But if the spine is fused together, what's that inversion table going to do? Nothing. Now if the surgery is fresh, that inversion table can actually do damage. So, we don't want to do that.
Would it like?
Why they combine the
Huh?
Why do they use the
Usually they do it because there's a bulging disc.
and that'll take away the pain?
So, here's a vertebrae, here's a vertebrae, and we have this squishy disc in between them that creates the padding between the vertebrae. Now, when there's a bulging disc, what happens is this starts to poke out and it puts pressure on nerves. It bulges out, it puts pressure on the nerves, and now the nerve is getting squished between the two vertebrae. So when they do a spinal fusion, they separate them again and bond them. So now there's no pressure on that nerve. So,
The disc is still bulging. There's just no pressure?
yeah, they
Okay.
can't fix the disc.
Isn't there like a way, like a special surgery? I'm pretty sure one of my teachers, like, he was a doctor and he was like a back surgeon, and he had said like he would help with that. I don't know.
Probably with a spinal fusion. Yeah. So, there's always new things coming out. So I'm sure if enough people get enough back pain and back injuries, they'll eventually develop some sort of device. Sometimes what they'll do is like you had mentioned your patient had a graft.
Mm-hmm.
Now a graft is where you get like cadaver skin bone and fuse it on there. Sometimes they'll even put like metal rods and pins.
You said cadaver?
Cadaver.
Is that still like?
It's a thing.
Like,
Yeah.
It's not like decomposed like bone stains.
Mm-mm. So, we always think of like organ donation, and this is getting slightly out of topic, but we always think of organ donation or donation in general is only the organs. We don't really think of all the other tissues, because they not only go for organs, they'll go for everything. They'll go for the bones, they'll go for the muscle, they'll go for the skin, they'll go for the eyes, and all of these get used as donor to someone else. You'll hear of a lot of people get cadaver bone in their mouth for dental procedures. They'll also use it for things like that too. The veins, the arteries, like they basically, like if you think of a car that gets scrapped, if a person opts to donate their body for donation, even if they're unable to get the organ, they will still go after the tissues, because the tissues seem to last longer than the organs do. The first tissue that ends up dying is the eyes, so that's the first one they take. It's wild. It's wild. No, actually, they do all sorts of things to make it look normal.
What, like
It's
glass eyes?
wild. Huh?
Like glass eyes or something?
So, like, let's say they go for the bone, they'll put in, like, PVC pipe.
What
Yeah.
the?
It will look like the person is completely normal, even though they scrapped it down. It's wild. Anyways, back onto a topic a little bit. That was slightly off topic. But, so they fuse the spine to relieve the pain. So is pain really a big one for this guy anymore?
No.
More like
Not since the surgery. They may have reported pain relief. Now this patient did do extensive physical therapy
Yeah.
because they said right when they came out, he wasn't walking. He was in a wheelchair.
Yeah.
Mm-hmm.
Now he's at the point where he's walking. So physical mobility is improved. What kind of nursing diagnoses will we think of this patient? What do we think?
is that powerless?
Powerlessness.
Powerlessness.
Now I'm looking at one, maybe 59.
Yeah, that makes sense. Ish.
Does he have a hard time bathing himself?
He didn't mention this.
Yeah, I didn't mention that.
Did he look like he was unbathed?
No.
Oh,
He
looks
actually very
clean.
clean.
Okay.
He didn't
So that's
smell.
probably not a good one for that guy.
His skin was like all
He was
bare.
like
Yeah.
on point.
All right, let's see.
Kept
Look
saying,
through them.
Why are you here?
53 chronic pain.
I would-
Now, chronic pain would probably be something before he had the surgery.
What about risk for injury since he's not like as flexible?
How was his movement?
Yeah, he has like good range of motion.
Good range of
Yeah,
motion.
He could move his arms.
He's pretty much like
We
him.
didn't see him walk though. Did you see him walk?
Yeah, I saw him walk. But he did fell.
He fell?
Yeah, he fell like a week ago, I think.
He fell a week ago.
Oh, he did
Yeah.
fall.
Oh wait.
And then he started feeling pain again.
So he fell a week ago. Now, once a person falls, they're more likely to fall again.
Yeah.
There we go.
So what do you think for his nursing diagnosis? Has any of your guys' other patients fallen?
So 47.
Oh,
Yeah.
Ours fell.
Well, yours jumped off a roof. But did he fall in the facility?
No. So 26. Rick's falls. Did we do
So
that
which
one?
number? Where are we?
26.
26.
66?
No, 26.
Oh, 26.
Rick's for falls.
Now, what about these medications also?
Yeah.
Gabapentin, cyclobenzaprine, and
They
baclofen.
make you dizzy.
They make you dizzy. They make you drowsy.
Mm-hmm.
Just like George. I think he took cyclobenzaprine this morning. There we go. Wakey, wakey. So I personally have taken cyclobenzaprine before. I slept the entire day. When I got up, super dizzy. Super dizzy. Now, with that one, if I took it day after day after day after day, eventually those side effects went away. Baclofen is another one. Makes people drowsy. Gabapentin works on nerve pain, so maybe your sensation's not super great.
Yeah, for which one?
So one for them. Risk for falls.
I think it was this one. I can't remember. What is it?
Baclofen?
Baclofen. I think for that one, I had put that basically like your muscles. It like not depreciates, yeah, but it loosens them.
Now there's one thing you guys are going to notice about the nursing diagnosis for a risk for is they are written differently. Because it's a risk, typically they don't have as evidenced by.
Whoa.
So risk for fall related to
Spinal fusion.
So, can we write spinal fusion on there? Or is that a medical
That's
diagnosis?
a medical.
Yes. So,
Some
how about
muscles atrophy.
muscles are frozen and cannot move? The muscles atrophy and spaz.
Yeah, we got it easy.
Because there's no as evidenced by and someone already took care of physical.
I need a picture of that.
Okay. So who's the last group?
George, get up there so we can have a break.
Alright, our patient is 70 years old. He was diagnosed with COPD, chronic obstruction of pulmonary disease. Alerts, he was showing no physical, CHF, not.
Conditional heart failure.
Yeah, CHF is conditional heart failure. For alerts, he wasn't showing any physical signs. The patient wasn't even aware that he had that diagnosis.
That kills me when patients don't know the conditions that they have.
I swear to God, we're talking.
How can they help themselves get better if they don't even know they have a problem?
I swear to God, we're talking
It's
to him.
like you have a bank
He's like, I'm
account.
fine. He's like, the most
So you
he's
have
like,
a
the only
bank
thing I got
account,
was this
and your bank
respiratory
account
thing.
is negative in the account. And if you don't go and look at that account, do you even know there's a problem?
No.
Do you know how to fix it?
Nah.
No. That drives me wild when people are like, I didn't even know I had that.
Like
Woo.
legit, he had
Okay.
a huge list.
Dude. And
He had
it's wild. Be interactive with your guys' medical care. That will tell you how good or how bad you're going to end up later on in life. You're going to be the 42-year-old that I had yesterday on hospice. Hospice! You know what hospice is? They've given up on life.
Care, yeah.
Just let me out.
Damn.
Wild. Oh, there's Laura. What's up, Laura? I texted you like we got here at 7, girl. Well, I know you're not a morning bird.
Yeah, that's true. So how much students coming here, or what do you guys?
We're about to leave.
We're almost finished, and then we're gonna go on a break.
Okay.
And then the thing is at the library.
It's at 11, right?
Yeah.
And then are you coming back here?
Starts at 11. Depends on how much we get finished.
Okay.
Yeah.
Okay.
If we still need to look at the books, we'll come back here. The
Okay.
nursing care plan books.
All right.
But if you wanna, you can go to the last skills lab and show your students the nursing care plan books. They should all be in the cabinet,
Okay.
so that way they can use them to work on their care plan.
Okay.
Yeah.
I'll do that.
All right.
See you.
Yeah, he's been diagnosed with major depressive disorder, and he can't bend.
Out loud. Louder, louder.
He's been diagnosed with major depressive disorder and can't bend his knees all the way down, but has full range of motion with the other joints. For past surgeries, he had an appendix removal at age 13. See his vital signs: he had a temperature of 97.6 with a pulse rate of 69, with the respiration of 17. He had a blood pressure of 118 over 71. For a pulse oximeter, we didn't get that one.
Ooh, that's probably his most important.
Yeah, we couldn't find the machine.
Okay, we are going to fib and we're going to say his pulse ox is 88. Was he wearing oxygen?
No, he wasn't wearing it.
But was it there?
It was there.
Yeah. Okay.
So for level of consciousness, he was fully conscious. He was pretty chill, very happy. You know, he was very cooperative
Very
throughout
cooperative.
the whole thing. His emotional status cooperative, cheerful, very cooperative. Speech, he was very clear, well spoken. His eye pupils were reactive and they were EOM. And the nice and white. His color was nice and white. So and his eye movements were very reactive.
So one question about his breathing, his speech, is was he able to say an entire sentence without taking a breath?
Yeah. He was
Yeah.
able to.
Okay.
Yeah, his ears, nose, and mouth, everything looked good. He didn't have no dry skin, no dry lips or anything like that. Moisture seemed fine. Yeah, his hydration is good. At first, I thought he was dry because when you would pinch it, it took a while to get back. But then I realized, he's just old.
He's old.
Yeah.
Sometimes
so,
it happens. Now you would use this as one piece of the puzzle, but also look inside the mucous membranes and you'll see they're shiny. Pink
Yeah.
and shiny is what we want.
Yeah. So like that all checks out. So I would actually fix that. For his heart rate, his apical pulse was 84. His rhythm was regular, but it was faint.
Very faint.
Like even with that
was so
one,
hard to
super hard. Yeah, his lungs. He did have a bit of wheezing. If you were to listen to about right here in his anterior, his upper anterior.
Go ahead.
Yeah, but I believe that's due to because he has past history of smoking, but he did recover from that addiction.
But the damage was already done.
Exactly. Yeah. Yeah, his abdominals, no obstructions. His abdominals were very active. When you would touch, it was pretty soft. No obstructions, no hard areas. Let's see, the sites were clear. For drainage, he didn't have any. For any extremities, put radio.
Yeah.
So peripheral pulse palpi or palpable was radial, and his nail beds were actually bluish.
His male beds were blue?
Yeah. Purple?
Yeah.
Okay, it was a bluish purple.
Okay. Bluish purple.
I'm thinking bruising.
What's the name? No.
Sinuses.
There we go.
Yeah, the limited movements on legs, had issue with lower back pain, chronic back pain for 10 years because he was a carpenter. Yeah, a little purple by the end of the nails.
What's going on back there?
For his arms,
Wrangle it in,
Full
or I'm
range
gonna
of
start
movement.
moving people.
joints were fine. Just his knee joints were messed up.
Kim can
Equipment?
probably ignore distractions a lot easier than I can because my attention goes everywhere.
The only equipment he had was the respiratory mask that was set on the side of his bed, so he would only probably use it as prescribed rather than constant. So overall summary, vitals are normal. Heart issues appear to be stable, and wheezing issues. Unable to stretch knees, and purple around nails. Claims that breathing is improving though. Like lately, so far he feels like he doesn't need that, but.
Okay. For like the passive physiology, congestive heart failure Okay. Complex clinical syndrome that can result from any number of cardiac or metabolic disorders such as ischemic heart disease, hypotension, hyperthyroidism, any condition that impairs the ability of the ventricle to pump blood can lead to heart failure. During heart failure, the heart fails in its ability to pump enough blood to meet
Sorry,
meet the
I'm sorry, meet the
yeah meet the needs of the body or
or can do so only with the sorry. My handwriting is pretty bad. So
So maybe you'll turn in the one that she writes.
to get it.
If I can't read it, then I'll definitely have it retyped and printed.
More of a typer type. Yeah. So, let's see. Ability to pump enough blood to meet the needs of the body, or can do so only with an elevated feeling of pressure. It's more clear. So, describe the picture for the ACE inhibitors. ARB, using ARB, beta blockers, MRAs, and diuretics. See the screen. Okay, so observing for effectiveness of therapy and for the client's ability to understand and implement self-management strategies. The diagnosis would be the actively intolerance related to decreased CO, excess fluid volumes related to the HF syndrome, anxiety related to breathlessness from inadequate related to the HF. Oh, I read to inadequate oxygenation, powerlessness related to chronic illness and hospitalization, and ineffective regimen management related to lack of knowledge. So he's only taking medications for chronic heart failure, and he wasn't even aware of it.
and the patient has only been taking medications such as atorvastatin, carvedilol, docusate, and furosemide. And pretty much like the meds that he's taken are acetaminophen, which is 325 milligrams oral every 4 hours per needed for like mild pain, or if his temperature goes to like 104 degrees. And then he'd be taking baclofen, 5 milligrams oral, 2 BID, muscle spasms, Dupalax, 10 milligrams rectally per needed for constipation, Fleet enema, 1 dose rectally every 27 hours per needed for constipation, folic acid, 1 milligram orally, once per daily for supplement reasons, and ipratropium,
The brand name is Atromet.
Yeah, there you go. Albuterol solution. The dosage would be for 0.5 to 2.5 milliliters orally for 4 times a day for wheezing and OPD. Milk of magnesia, 400 milligrams or 5 millimeters orally per needed. If there's no bowel movement for every 3 days. Multivitamin/minerals, 1 tab orally once per day for dietary supplement. Pantoprazole, sodium tab, 40 milligrams orally once per day for GERD or without esophagitis. prednisolone solution, 15 milligrams or 5 millimeters orally once per day for chronic obstructive pulmonary disease with acute exacerbation. Tamsulosin, HCl capsule, 0.4 milligrams orally once per day for BPH or obstructive and reflux uropathy. Vitamin C tablets, 500 milligrams orally once per day, promote wound healing. Zinc tab, 220 milligrams orally once per day for supplement.
So what I'm hearing just from their list of meds is their one patient had a majority of your guys' issues. So I heard the medication Tamsulosin, that was your guys' with the urinary. I heard the medication Baclofen, which was muscle spasms. I heard the medication, what else did I hear? Let me see. Prednisolone, which is a hormone.
He's
Yeah.
got a lot of medication.
Oh, pantoprazole, which is the stomach ulcer guy. So this dude had a lot of issues. Now, our main issue we're going to work on for him
Yeah.
is the heart and the breathing. So when we look at his head to toe, did we see that heartburn and stomach issues was a problem?
No. At
Did
least
we
not
see that muscle spasms was a problem? Did we see that urinating was a problem?
Actually, yeah, it was recently
Uh-huh.
that he started urinating about 6 to 7 times a day.
More frequently.
Yeah, but
That's
it's
why he was put on the Tamsulosin.
Mm-hmm.
Now, when we did our assessment, when we look at all these pieces of the puzzle, his saturation 88, his wheezing lung sounds, his nail buds having cyanosis, do you see that as his bigger problem? Yeah. So let's look up on the board and let's try to figure out what problems we may have when it comes to delivering oxygen to the body.
These are all his cardio.
So impaired gas exchange would be something inside the lungs, and that would mean that the lungs are having a hard time absorbing gas in. Now for this client, he has CHF, where the heart fails to pump enough blood to meet the needs of the body. So let's take a peek at maybe 72.
Ineffective tissue perfusion, specified type, renal, cerebral, cardiopulmonary, gastrointestinal.
So when it says impaired tissue perfusion, specify the type. Is he having an issue getting blood to the kidneys? No. Is he having a issue getting blood to the brain or the cerebral?
No.
No. Is he having issue getting blood to the heart?
Yes.
The heart's pumping. If there was an issue getting blood to the heart, that'd be heart attack. Is he having a heart attack?
No.
No. So the blood is getting to the heart just fine. What about gastrointestinal? He has a hard time getting blood to the stomach. No. What about peripheral?
Peripheral vision?
Where are the nail beds?
Right here.
That's not literal, that's figuratively. So when we talk about things that are central, they're toward the middle. When we talk about things that are peripheral, they're towards the outside. So are the nail beds peripheral to the heart?
Yes.
Yes.
Yes. So is he having a hard time getting blood flow to his nail beds? So it would be ineffective tissue perfusion peripheral. related to what?
Related to heart failure.
Now, heart failure, is that a medical diagnosis?
But like chronic. Oh, okay. Unable to pump blood.
So when we say diastolic heart failure, systolic heart failure, those are all medical diagnoses.
Not pumping.
Or not pumping enough blood.
What's our evidence?
Evidence by purple.
Cyanosis located in the chest.
That's more of a long one. So if you guys had CHF and COPD, since you guys picked CHF, it would be the heart failing to pump blood out to the body. If you guys pick COPD, now let's do a two nursing diagnoses since this is our last one, and we have some extra time, extra 10 minutes. So with COPD, what would be a better nursing diagnosis for COPD? So breathing pattern would be towards the end of people's life, they do what we call agonal breathing, which is more like a gasping breath. Mm-hmm. So they'll be like, so that would be an ineffective breathing pattern. Or what about people who are hyperventilating? That's ineffective breathing pattern. Or people who have sleep apnea, where they're sleeping and they stop breathing in their sleep. That's an ineffective breathing pattern. Now, for him, he's a smoker, so probably that's what caused his COPD. Remember, COPD is an umbrella term for also emphysema. It's emphysema, asthma, and bronchitis, chronic bronchitis. Those are all three things that are located under COPD umbrella. So, for him, he has COPD. And remember, we have our airways with the bubbles, the alveoli. And with smoking, the alveoli gets gunky. It gets filled up with sticky tar. So, CO2 cannot be removed, and oxygen cannot go into the blood. So for this patient, can the gases CO2 and oxygen be exchanged?
No.
Which one is it?
Number 32.
Which is?
Gas exchange.
What's our related to?
Related to wheezing? Oh wait, that'd be evidence, right?
Yeah, sure.
What's happening right here? Put that into words.
Related to tar
So yes, it would be tar.
related to CO2 buildup in the lung?
Tar buildup in the, what are these? Alveoli. And what is that tar buildup doing?
It keeps the oxygen from going.
Blocking removal of oh my goodness, of CO2 and absorption of O2. What's our evidence?
Evidence by
Sea level oxygen therapy.
Lung sounds wheezing. What else do we have?
Oxygen therapy.
That's right. Pulse ox.
Pulse ox 88%. What about
bad,
this
or-
one? Oh yeah, that's not good.
No.
What's our normal pulse ox?
Should be like around 100.
98.
95 or above.
Yeah.
Yeah.
Now there is a permissive hypoxia when it comes with people with COPD, where the doctor may order keep pulse ox between 88 to 92. Why is that?
Because it's too low.
Why do we want their pulse ox to be lower?
Is it because they can't handle like higher amounts of oxygen, or?
Very close. So when we breathe, this is where you and I are breathing. Our brain detects our CO2 levels are too high. Take a breath. We blow off extra CO2. And then our brain detects it's normal. So then our brain stops working. Then our brain feels that level going up again and we go, and we take a breath. Blow off that extra CO2. That's for people with normal anatomy. But with COPD, what's happening to that CO2? Can it escape?
No.
So the patient takes a breath, CO2 is still high. We didn't fix it. Brain does again. Take a breath, CO2 is still high. So the brain is eventually going to think, no matter what we do, CO2 isn't changing. It's going to turn off that normal breathing mechanism. The brain now has to compensate a different way to breathe. How does it do that?
Based on oxygen.
Now it goes off of the oxygen. So the brain says, okay, oxygen level's going too low. Take a breath. Oxygen level's going too low. Take a breath. So their brain chemistry has changed because of that tar buildup inside the alveoli. So now, what happens if we get their oxygen up to 100%? What does the brain think?
Stop breathing.
I have enough oxygen. I don't need to breathe anymore. We have plenty. No more breathing. Is it safe for the patients to stop breathing?
No.
No. So, do we want to give a patient with COPD who has these ordered parameters extra oxygen?
No.
No. I believe that will end up somewhere on state boards. That whole concept. Cool? So we got 2 nursing diagnoses for you guys if you guys want to do one way or the other. So you guys got, be back here by iPhone time at like 10:50, so we have time to walk over there.
Wait, so daylight savings time to pass or something, or what?
I am going to snack
You said
this
iPhone
school.
time. I was like,
iPhone time.
Yeah.
Because look at what that clock says.
oh,
It's not the same time.
oh good.
Well, I was thinking the first one.
Daylight savings time. I haven't. No.
Do you want the second one regardless if you take a picture of it?
When is that? It's this month sometime, right? Okay.
It just happens, and my alarm goes off when I
Right?
wake
And
up.
like,
So you
oh,
shift, but that's what we focus on, huh?
Yeah.
Ooh.
It's so cold in here. How come it's cold in here when it's hot outside?
Bro, we gotta make something
Probably because I complained about it and then
Right.
they did change it, but now we're too like,
How do you withstand this freezing temperature?
Huh? You can't even withstand it. You can't even withstand
Not that.
I was thinking of maybe getting a snack, but maybe not. I don't know. I was gonna start heading over there.
It's the battery like crazy.